Good morning, and I would like to welcome everyone who is present in the chamber and all those who are listening online to the business of the Health Scrutiny Committee for Lincolnshire. I would like to add, for those of us that are in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception, and assemble in the car park at the front of the building and await further instructions. I would also request all members to place their phones on silent and to try and ensure everyone has the opportunity to ask a question, to ask a maximum of 2 questions per item, and to keep these succinct and concise. However, I will close down the debate to ensure we keep to time if needed, and would ask you indicate early to guarantee your question. As the meeting is being streamed in the usual way, I would like to remind you all that your comments will remain accessible online, as the meeting recording remains on the council's website. I would like to welcome Derek Ward, the County Council's Director of Public Health, who is present in the council chamber today, and I will introduce other presenters as we reach their item. Now I'd like to move into agenda item 1, apologies for absence and replacement members. Trina.
Thank you, Chairman. We've received apologies for absence from councillors Charmaine Morgan and Sarah Parkin. We've also had an apology for absence from Councillor Sue Woolley, Executive Councillor for NHS Liaison, Integrated Care Systems, Registration and Coroners. Thank you.
Thank you. I'd now like to move into agenda item 2, declarations of members' interest. This is an opportunity for members of the committee to declare any pecuniary or other interest. Do members have any interest to declare at this point? Councillor Kendrick, please.
Thank you, Chairman. I'm a stakeholder governor of LPFT. Thank you.
Thank you. In which case, we'll move to agenda item 3, the minutes. This is to confirm the minutes of the meeting held on the 4th of October 2023 as a correct record. They are found on pages 3 to 9 of the agenda pack, and as the committee has had the opportunity to read these in advance, I plan on taking these on block. Do I have a proposer, please, for those? Councillor Mackinson-Saunders, seconder, Councillor Smith, and all those in favour, please show. Thank you. That's supported. Any against? And any abstention? No. Thank you. In which case, we'll now move on to agenda item 4, the Chairman's announcements. My announcements were circulated as part of the agenda, and supplementary announcements were circulated on the 7th of November. Does anyone have any questions on these announcements, please? Councillor Smith.
Thank you, Chairman. With regards to the whistleblower that's mentioned in your announcement, this was quite a surprise to me, and also in a sense reassuring us that this is the same concerns we expressed. As this has now been formally whistleblown, does that mean that a proper investigation by the relevant bodies will now take place to ensure that those concerns are adequately addressed? Thank you, Chairman.
Simon, I'll bring you in on this one.
Thank you, Chairman. I can certainly try to answer that question. I'm not aware that there is anything further. We are covering that item as part of the acute services review after the first item this morning. Thank you, Chairman.
Thank you. Councillor Allen.
It's to do with item 4 on the Chairman's supplementary announcements. Are you happy to take that as well? Query?
Most certainly, yeah.
It's to do with the revised health scrutiny regulations and statutory guidances, because when I read that, I thought the powers of this committee were being limited, but from a discussion that took place in the members' room, it does seem as though they might be enhanced, and I'm a bit confused, Chairman.
Yeah, thank you. I think what's happening is that they are probably not being enhanced, or actually being downgraded. However, what I was trying to explain previously is that this will now automatically, if it constitutes a major change, land on the Secretary of State's desk anyway for him to take an opinion on. At the moment in time, our power is to refer it to him. So in essence, he should have the opportunity to then look at something we're concerned about. My only concern with all this is, with so many major changes that are taking place, will actually, you know, this be looked at and taken in the same light as if a committee would be referring that. So that would be my concern with it. Councillor Mackinson-Saunders.
Thank you, Mr. Chairman. Number 7, earlier mental health support has been announced. I was listening to something on the radio coming over, and it is quite important that we try and get some in Lincolnshire, because so many children are missing their schooling, that if we can help them back into school and support them through any crises they're having. So I hope we'll all fight for some in Lincolnshire. But 5 million isn't a huge amount of money spread around the country, so I appreciate it's going to be difficult.
Thank you, Councillor Mackinson-Saunders. What I would say is I think there's been multiple millions that have been poured into mental health services at the moment in time. So I think the whole package hopefully will work, and I think it's been identified and it's fresh in the mind, and will ensure that we keep getting our mental health items brought forward to ensure that we're aware of how it's progressing. Any other questions, please, on the announcement? No, in which case do I have a proposer that we note them, please? Thank you, Councillor Smith, and seconded Councillor Kendrick. All those in favour, please show. Thank you, that's supported. Any against? Or any abstentions? No, thank you. In which case we'll now move on to agenda item 5. We've got the Humber Acute Services Review. This item was circulated as part of the agenda pack on pages 15 to 49, including the consultation document. I suggest the focus for the committee is firstly to consider whether it has all the information it needs on the impact of the proposals on Lincolnshire's patients, and secondly to take a view whether the committee would like to respond to the consultation. I'd also like to welcome Councillor Stephen Bunny, who is a member of the joint committee for this item. So welcome, Councillor Bunny. I'd also like to welcome our presenters all via Teams. So from the NHS Humber and North Yorkshire Integrated Care Board, we have Alex Seal, North Lincolnshire Place Director, Lindsay Cunningham, Associate Director of Communications for the Humber Acute Programme, and our presenters from North Lincolnshire and Gould's NHS Foundation Trust, Dr. Answer Qureshi, Consultant Acute Physician and Clinical Lead for Elderly Care at Scunthorpe General Hospital, and Kerry Carroll, Deputy Director of Strategic Development. I understand you've got a PowerPoint presentation for us, and if you could go in across this in about 15 minutes, and questions at the end, please. Thank you.
Thank you very much for the introductions. Yeah, that's right. We do have a presentation, so we're gonna walk our way through that presentation for you, and then obviously an opportunity for questions, etc. So I'm going to start, and then colleagues are going to be contributing as we work our way through that as well. So just a quick recap really of the key drivers for the changes and some of the key challenges that we've seen in the acute hospital services that have caused us to take forward this piece of work as well. So primary one to mention first is around workforce, and we do know that, and I don't think this is an issue common to this area, that this is an issue that's seen nationally, but particularly challenging in our areas, being able to recruit the right workforce in the right place to be able to support and meet the demand pressures that we have. So we do find in certain specialties, for example, in certain areas, despite a number of extensive efforts to look at how we do recruit into particular specialty areas, we do struggle to do that as well. And that includes initiatives such as international recruitment, and all those processes continue to happen, but it is challenging, and we do have considerable vacancies in areas, and that does contribute, and we're often having to use agency staff to be able to support that issue as well. We do also know that obviously quality and safety is a critical issue for us. Excuse me, and actually being able to meet some of the key targets around waiting lists, for example, and urgent care, we're not doing that at the moment, and that's exacerbated by some of the pressures that I talk about here, and about making sure we've got the right workforce in the right place to support that issue as well. So to enable us to consistently meet that into the future, we need to look at how services are delivered to support that. We are experiencing significant pressures around our growing aging population, so demand for services has increased across the piece, which obviously puts pressure on health services. And we are very keen, and throughout the process, focusing that we meet the needs of our population, particularly focusing on those people who struggle to access care as well. So you'll see as we go through the presentation and we look at the option that we're proposing to take forward, we focused on that which has the least impact, on particularly focusing on some of our deprived population areas as well. Investing in our buildings is a key challenge. We did put a national bid in for additional capital, substantial bid to the new hospital programmes, which hasn't been successful, but we know capital is constrained in the system, and we know we have major capital challenges, which does impact on the ability for us to deliver our services. And then we have a key requirement as well to make sure that we do use our financial resources in the most efficient way, so that we know we're directing that to improve in patient care and public-facing services. So moving on to the next slide. So what are we proposing? So that we have looked at a whole range of proposals in going through this process, and I'll touch a little bit on this on how we've looked at this against a set of key criteria in a later slide. But we've looked at a whole range of best options, and it's been hugely driven by the pre-engagement work that we've already done prior to the commencement of the formal public consultation, but the work that we have done with clinical staff and professionals to shape the future models that we have. So as I said, on the basis of that work, our current services are not always meeting the needs of our population and are not necessarily set up to do that in a sustainable way for the future. I've touched on the issue that clinical teams are spread too thinly. So particularly when we look at some of our more complex and specialist services, we're spreading staff across multiple rotas. And that does have an impact for staff as well, because staff are not all therefore getting the opportunities to maximise their skills in doing that. So you'll hear from Amware, we often have multiple rotas for very small numbers of people are being seen, but that does spread our staff in an inefficient way and doesn't present the best model for how staff are working to give that patient-focused, multidisciplinary approach as well. As I've said, our infrastructure in hospitals is failing. And limits not only what we can change, but where the change can take place as well. So that is a key determinant in terms of that element as well. And then focusing really on what the proposed changes do in terms of improving outcomes. At the moment, for example, we aren't able to deliver 7-day services across a range of our services. And Amware will talk about a case study that demonstrates the impact of this if people can't be seen 7 days a week, and how we make sure that if we do consolidate some of our more specialist services, people can be seen on a 7-day basis, get the diagnosis, get their treatment faster, get out of hospital more quickly as well. As alluded to, our proposed changes aim to support improve recruitment and retention and to introduce new skills as well. So by consolidating those teams in that way, we have an opportunity to do that. And we do know that when we take that kind of action, we do find that recruitment is improved because people want to work in those kind of teams as well. And then another real positive is our proposed changes maximise the benefits of the investment of 35 million in our 2 new emergency departments. So we have new emergency departments in Down Prince of Wales and Scunthorpe Hospital. That's made a really beneficial impact on supporting people flow through those systems as well. And that will not change in these future changes. There will continue to be that 24/7 emergency department front door, and we'll be really maximising the benefits of those 2 new emergency departments to support that as well. As I said in my first slide, we have chosen to consult on the approach which minimises the impact on our patients, our staff and our neighbouring health systems as key parameters that we need to do in proposing these changes. And a critical point is to say that the majority, so over 93% of people who currently attend our services would continue to get the services in the same way that they do now. So there is still that facility for people to attend the urgent front door, and as you'll hear, the impact is on a much smaller group of people where a more specialist support is needed. And then next slide. So we are now, I think, over to Anwar. Welcome, Anwar Qureshi, who's going to take us through the clinical models that's proposed.
Thank you, Alex. Good morning, everybody. I'm Anwar Qureshi. I'm an acute care physician at NLAG and clinical lead for hazard urgent emergency care. Sorry, I was a bit late because we have an external visit today for our emergency care at that hospital site at Scunthorpe. So just briefly to tell you what will remain, and that when we say what will remain, there is some addition to the services we are thinking of implementing, which is so 24/7 emergency department with the urgent care service will remain. Acute assessment unit, which is where the medical patients get assessed and are admitted through, will remain. Same day emergency care, which is our pathway where patients who are seen and managed on the same day and sent home, who previously used to get admitted, some of them because of waiting for investigations. Now that's the pathway we use, and we've been doing it for now good 4 years. That will remain. And then the short stay, which is our acute medicine, and patients who require less than 3 days of stay is the area that will still remain. Patients who require admission beyond those 3 days in the local hospital will stay there as well, which is our elderly patients and the general medical patients who do not require any specific specialty will remain on site. Emergency surgery day case will remain. It's only the overnight specialized surgery that will move to one site, which is Grimsby. This, when we say day case will remain, that will include fractured hips, because that is a common condition that is in our frail and elderly population. And isolated hip fractures can be managed locally because the guidance is to manage them or operate on them within 36 hours, which we will be able to do on site at Scunthorpe. For children, the assessment unit will remain, which is up to 24 hours. Critical care anesthesia, which is the ITU staff and our teams that provide anesthesia for surgeries, will still remain. Obstetric-led unit, which means medical-led unit, which is the which is already existing in Scunthorpe, will remain, along with care for the newborns. Planned surgery, which is day case and other planned surgery and outpatient services, will remain, so nobody has to travel for their clinic appointments. Stroke service was centralized 12 years ago at Scunthorpe. That will remain at Scunthorpe. Next slide, please. With that, you could see that, you know, the important bit is we have invested 35 million in our EDs to have that new fully equipped emergency department at the front door in Scunthorpe Hospital. The bits that will change is that for a population that we have in North East Links and North Links, we require one trauma unit. So that's going to be based at Grimsby. Emergency surgery, as I've already said, overnight will be at Grimsby. Some medical specialties, which is cardiology, gastroenterology, and some of respiratory medicine or lung conditions, who are complex patients with lung conditions, will be admitted at Grimsby under a specialist team who will be available for them 7 days a week, which we do not have at the moment. Currently, we hardly able to do 5 days a week on both sites. Pediatric overnight care for the first 24 hours will remain on the site at Scunthorpe, but beyond that, if a child needs to be an inpatient in the hospital, we'll go to Grimsby. Next slide. So just to give you a quick taste of what that means. So for cardiology, for example, which is heart, patients who come with chest pain, there could be 3 different scenarios. One, a patient could come who may not have chest pain, has fluid overload, requires diuretics or drugs to get rid of the fluid intravenously. That kind of patient would be admitted locally. That treatment will be received through the emergency department and acute assessment, and then will be going home from Scunthorpe General Hospital after being treated. Second is, say, Alexis, who comes into emergency department, has a blood test after having had chest pain, which shows there's a mild heart attack, gets tests and investigations done, and cardiologist has to see that patient within 24 hours. Now, what we do not have currently on any site is that if the patient turns up on Friday. So we do not have any Saturday or Sunday service for any cardiologist. Now, that patient, if now in the proposed model, if this goes ahead, would on a Friday be seen by a medical team and then be transferred to Grimsby to be in Grimsby so that the cardiology team, which is available for 7 days, would see the patient next day, and if advised a procedure, that would be done by the next 72 hours and the patient will be going home. That's the proposed change. The third situation, which is of Bill, who has been picked up from home and seen to have a barn door heart attack, would go to Castle Hill. That happens even now. So that pathway will not change. Next slide, please. For trauma, there are different scenarios again. So if somebody is on a walking about or on a trampoline and twist the ankle, they will come locally to our urgent care service and then be treated. If they do not require any operations, they will be treated locally and then sent home with a back slab or a plaster cast. The second scenario, where if somebody falls from a ladder, for example, conscious, does not have any head injury, but has broken several bones, which may require operation. Paramedics will pick that patient up and take to the nearest emergency department that has trauma in it. So people can be picked and going to Doncaster, people can be picked going to Hull, people can be picked and going to Grimsby, depending upon which is the nearest site of the trauma center. And they would go there, be assessed, and then operated upon if required. That is the change in the pathway. Whereas Sophie, who's a trauma patient who may have had a high-speed road traffic collision on A180 or M180, will be taken to the major trauma center if she's sustained multiple injuries anyway, and will be picked up by a helicopter or an ambulance, depending upon the time that they've calculated that'll take the ambulance crew or to take the patient to the major trauma center. Based on that, be airlifted or by ambulance. That pathway already exists and doesn't change. Next slide, please. So I'll pass on to Kerry for the data. Thank you.
Thank you, Anwar. Thank you. So this slide shows the activity modelling against the proposed service changes, which Anwar's just explained. The numbers on the screen are taken from 2019 full year activity, showing those from a Lincolnshire postcode that attended Scunthorpe General Hospital in that year, who would potentially be impacted in terms of displacement from Scunthorpe, totaling just over 450 patients for the full year. Just a key message to add to the slide, that the modelling is assuming that these patients will still continue to access Scunthorpe General Hospital Emergency Department, as that will remain. The ones where anticipated may be a change at source will be any trauma ambulance conveyed patients, whereby the ambulance service will transfer that patient direct to their nearest trauma unit from the scene. And those numbers are the ones in the first column around about the 64 mark, we're just remodelling. Thank you. So just key messages on the numbers there. I think I'm handing over to Lindsay.
Me and then Lindsay. That's great. Thank you, Kerry. That's really helpful. And Anwar as well. So just touching on what my point at the beginning of the presentation about our pre-engagement work, which was extensive. And as I said, we explored a number of different ideas and using a set of criteria, particularly focusing on that which would have the least impact on people. This is the proposal that we've put forward as a result of that pre-engagement and the work that we've done to look at that previously. Just in terms of some of the external assurance processes that we've been through, we've been working all the way along the line with the Independent Clinical Senate, which is an independent group of clinical professionals who assess the proposals. And they provided their highest level of assurance to the proposals that we've put forward, and did highlight that the current service models for the future were not sustainable. And then in terms of the engagement process that we've undertaken, we've been working with the Consultation Institute, and they have put forward that this is an effective pre-consultation process. So they have provided that assurance as we've gone through this process. And you can see on the diagram the type of activities that we've done to support that as well, which have been a whole range of different modalities of understanding, and that's helped to shape the proposals that we've put forward. Apologies for that, Lindsay. So just a little bit more on the detail for those people who are interested. We've extensively looked at the data flows and intelligence and what they've told us about the best possible models for us to look at in the future. We have looked at workforce analysis, including tracking where all our staff move around in the patch at an individual level to understand what the implications of changes would be and what the implications would be on the staffing requirements to deliver the potential models as well. We've also undertaken travel impact mapping as well to concern travel impact for staff, for patients and families. So we understand what the implications are of the proposals of change. And we've also looked at the same piece of work around blue light ambulances and the requirements for transfers between sites as well. So we understand what the impact of that is, which for the purposes of the proposal we put forward is half an ambulance, which is something that we've worked on collaboratively with East Midlands Ambulance Service, and they are comfortable that that is something they can meet within their business as usual implications. We've also focused significantly around health inequalities and our integrated impact assessment, working with, engaging with our local communities, understanding our potential in health inequalities and the impact, and then how we mitigate any potential negative impacts around that one as well. And I'll talk a little bit about transport and travel and the work that we're looking at around that one as well. We've looked at activity models because we have a requirement to ensure that we're not having a detrimental impact on other systems in terms of displacement of potential models outside of the area as well. And then we've done significant bed modelling and site surveys to understand the requirements of the service delivery model that we've got in the future. And that's the process that has taken us to the proposal that we've put on the table. So moving on to the next slide. So key impacts as we're going through the consultation, around halfway point through the consultation at the moment, we are doing significant work to understand any of the key themes and issues that are coming up and working on how we can mitigate and minimise any potential impacts as we go through that process. So as you would imagine, travel and access, both for individual patients, but carers, families and visitors is a key issue, and we have established a transport working group, which is a really active group looking at what other potential options, community options, etc., could be used to support that as well. So we're exploring with colleagues in local authority, with other partner colleagues, how we could use some of that transport capacity differently to support and mitigate some of the impacts, and some positive conversations already developing around what we can do around that. Discharge through hospitals to make sure that we don't, by moving people, we don't impact on getting people home as quickly as we can. And we do have a really well developed integrated discharge hub through our hospitals as well, which support discharge flow. And we do have a sort of positive position in terms of getting people out of hospital quickly. We've been working as well, looking at contingency planning and major incidents as well. So if we did, for example, road closures, the A180, making sure that there are alternative routes to deliver that, which there are already protocols in place to be able to support that as well. And working with our EPR, our emergency preparedness and resilience colleagues to look at how we support that in the event of a major incident. And then whilst the changes in this particular area don't impact on GOUL per se, there is a small component of the GOUL population that are potentially affected by that as well. So we've been doing some specific engagement activity with GOUL as well. And then moving on to the next slide, which I think might be Lynn's.
It is. Thank you, Alex.
Thank you.
Sorry, I'm having trouble with the buttons. I've only got one screen this morning, so apologies. I'm driving very badly. Conscious of the time, so I'm going to rattle through the last couple of slides really briefly, Chair, but I just wanted to cover off, I'll skip past this one because this just gives the outline of the consultation shape as it was when we launched. But what I wanted to just cover briefly is a summary of the engagement activity we've undertaken so far, and crucially what's still planned to take place over the remainder of the consultation. So we've chunked it up into the widespread promotional engagement that's open to everybody, targeted work, and then right down to the initials on the bottom stand for playing on, and I'll explain what that is in a moment when I get to the next slide. So We've done a lot of promotional work around the launch of the consultation. We've sent summary leaflets and posters to around about 120 different community locations, and that was across North Lincolnshire, North East Lincolnshire, East Riding, and into Lincolnshire County Council area as well. We've shared them with libraries and other community groups that we've got contacts with at this point in time. We've also obviously done a lot of work around working with the media to proactively launch the consultation and have managed to generate a reasonable amount of coverage in local radio, TV and press. We have a regular newsletter which goes out to now around about 1,000 subscribers. My apologies, there's I think fire alarm tests going off, so if I have to disappear, I'll let one of my other colleagues finish. We have held several exhibition events. So we've had 3 so far, which were in Goole, Grimsby and Scunthorpe, and I'll come on to what's planned for the next phase in a moment. And we've also been undertaking some targeted focus groups, and we've got more of them planned. In terms of the remainder of the consultation, the key elements that we are planning next, and the ones that were particularly of interest to this committee. We have 3 additional exhibition events scheduled. We are running 2 more in Scunthorpe. That's partly because the weather was so bad on the session that we did hold. So we want to make other opportunities available, particularly because the majority of the impacted population live in and around the Scunthorpe area, and they will be in central locations that are easily accessible. So even for people, if they're able to get there from sort of surrounding villages. And we are also hosting another exhibition event in Gainsborough. Unfortunately, I don't have a date for you. Because we've been really struggling to get the venue confirmed, but we are looking at that being the week commencing the 4th of December. And as soon as I have the details, I will share them with the committee clerk so that can be shared amongst all members locally as well, so that you can support us in getting people out to that exhibition event. In addition, we're doing what we call pop-up engagement roadshows. So we're visiting lots of smaller communities and ensuring that we get out and about to places that are busy, that have got high footfall, that have got people coming regularly. And most of them are planned in to the end of the consultation period. That will include, we've just confirmed a venue at Louth. We're going to be in the library on the 29th of October. Obviously the Gainsborough one that I've mentioned, and we're looking at the other dates for those between now and Christmas. The other piece of work that we're doing is this targeted engagement, so focusing on much smaller numbers of people, but having more in-depth conversations, and actually that's where we get a lot of the really useful and rich feedback from local people. We've held a number of focus groups and discussion groups with parents, parent carers, and people from some of our deprived communities. And we have got 6, I think it's actually 7 now, because there's another one just landed in the diary just as I was coming on to this meeting. Further focus groups taking place, and that includes with another group of carers, with the Youth Council, with Disabled Club, working with our Armed Forces community, so working with the Veterans Hub in Scunthorpe to have something specific for Armed Forces communities, and one with another group for predominantly people with learning disabilities. And again, we've produced the documentation in easy read to support that engagement. We also, one of the other groups, I think the one that just landed in as I was coming, was a group in Scotter, so that will be taking place late November as well. And then the final strand of engagement that we're also doing is a number of drama groups. We're working with a company called Playing On, who specialise in using drama to engage with people who are potentially harder to reach or often not heard in consultations like this. And we've had one of those groups took place couple of weeks ago working with children, and we have another one coming up in the next couple of weeks. We've got one with children and young people, one working with a group with learning disabilities, and another with other vulnerable adults. So we're looking at different methods to engage with different groups, and that's in summary what's planned for the remaining 7 or so weeks of the consultation. I'm just going to onto, I think this is our final slide, which just sets out the timeline and what's next. Obviously, we've had the first meeting of the Joint Health Overview and Scrutiny Committee, which members from this committee joined. We will continue to engage with all of our stakeholders during the consultation period, which closes on the 5th of January. And following that will be a period of reporting, analysis. The analysis is being undertaken by an independent organisation who will present the findings back to the Integrated Care Board for decision making in the spring next year. And then subject to that decision making, any implementation would happen on a phased basis. It wouldn't all happen overnight, but we'd expect that to take 1 to 3 years, depending on the level of building work or investment that was required for each of the different elements of change. So I'm going to stop there and I'll take the screen down so that I can see the rest of the room, and apologies for slightly overrunning, Chair.
Okay, thank you. Okay, questions, please. Okay, I've got Councillor Kendrick first, please.
Thanks very much, Mr. Chairman. I was just interested in what I think one of your first slides, you state infrastructure failing, and I was just interested to know if you could expand on that. It sounds concerning that this has actually happened, obviously, over a period of time. So I was just wondering if you could expand on that statement which says infrastructure failing. Thanks, Mr. Chairman.
Yeah, thank you. Do you want me to pick that up? And I'm sure colleagues will come in as well. So we do know, and particularly focused around Scunthorpe site, but there are also that we have some significant capital challenges and backlog capital challenges. We did put a proposal, a business case through nationally to be part of the new hospitals programme, and unfortunately that wasn't successful. So in looking at the proposals, we obviously need to consider the infrastructure to be able to support the proposals. So in looking at the proposals, one of the drivers around the centralisation of the more specialist elements of the service at Diana Princess Wales Hospital is that there is a less of a capital infrastructure requirement to deliver the changes within that site as well. So that is why we have chosen that. But as well as that, it does have less impact on population and patient flows if we look at that site as well. So obviously there is a whole piece of work going on around looking at the backlog and the business maintenance and making sure that we're able to deliver that. But the requirements of capital that would have been required to get Scunthorpe into a position to be the site for the more specialist elements was prohibitive in terms of taking this piece of work forward as well. So that's the background in relation to that piece of work. We're continuing to work obviously nationally around the capital and how we continue to support that, those challenges as well. But the reason that is one of the drivers around why we've looked at Scunthorpe as opposed to Diana Princess of Wales Hospital in terms of that, because that would have required significantly more capital to enable that to happen.
Thank you.
Thank you, Councillor Kendrick. I've got Councillor Smith next, please.
Thank you, Chairman. It's not so much a question. It's I know you and I, and Councillor Bunny, when we attended the main event, as it were, and the joint working, we had a number of questions that weren't answered, and we pre-sent those. It's just if the presenters had time to go through those. If not, I'm not proposing to go through them as there are a number of them, Chairman, but I will send them to Simon, and if we could get answers to those in writing, that would be helpful. One thing I will add, Chairman, I am grateful and welcome the inclusion of veterans now into the process and at Scunthorpe. My question is, how are you engaging with veterans here in Lincolnshire? For example, there are a number of veterans breakfast clubs. There is one in Gainsborough, there is one in Market Rasen, and I'm sure, and there is one in Scotter. Those are just the 3 I know of in West Lindsey. I'm sure there are others across the county, and I'm sure there are other means that the veterans could be engaged with, especially as you said, Chairman, when we had the review here in Lincolnshire, every household got a letter. Now, I'm not saying that they should do that to necessarily every household in Lincolnshire, but certainly those areas most affected. So that would certainly be, say, Gainsborough, it would certainly be other divisions that are impacted, say my division, Councillor Bunny's and others, that they should be consulted personally in the same way, because then you will catch every veteran that lives within West Lindsey and within Lincolnshire, because West Lindsey is the 4th largest area for veterans in the country, Chairman. So it's important that those views are captured, because often they will have dual complexities and comorbidities that will need treatment, and will need to be treated for in possibly in certain circumstances in a different way. And if you don't have that data and that knowledge, then you're long term you're going to have medical problems, which is going to cost you the taxpayer more money and also give them worse outcomes, which is more important that we avoid. Thank you, Chairman.
Thank you.
Lindsay might want to comment on.
Thanks, Alex. Yeah, we will make sure we get written. Simon, if you could send those questions across, we'll be able to gather and provide some written answers. That's not a problem at all. In terms of the engagement approach, we are working with colleagues within the trust within NLAG who have quite an extensive veterans and armed forces community as an employer, and actually using that to reach out. We have also been obviously engaging with colleagues in the local authority areas. If you have any additional colleagues within Lincolnshire County that you would like to connect me with, that would be really helpful, and we'll happily support any further engagement opportunities that people want to suggest. Always happy to go and talk to people if connections are made.
Thank you. I think just picking up really where Councillor Smith was coming from, as was alluded to, I think in Lincolnshire we had a very robust way that the acute services review was done, in the fact that every single resident received a letter making them aware of that consultation and gave a richness in responses. And I think I have a number of concerns in the fact that this hasn't been done by yourselves. And I think if it came down to a judicial review, you might struggle without doing such a thing. I'll bring in Councillor Allen next, please.
Thank you, Chairman. That was one of the points I was going to make in relation to the consultation, because these things are far-reaching, and it's important to get views as many people as possible, particularly that, from prospective patients that might not be in the immediate catchment area, because there is such a lot of movement across authority boundaries and indeed NHS boundaries. The point I was going to make is that we and it's a point, I'm afraid, rather than a question, is that we get these sort of consolidation ideas from various trusts, and we've had a number of these sort of things, and they are always marketed as providing a better service, but really I think what it is providing the best service that we've got with the resources that are available to us, whether those are professional staff or whether it's buildings. So it does seem to me to be a bit of a misnomer to say, it's providing a better service. It provides a better service with what the NHS has got available to itself. I'm not totally sure it provides a better service to the patient, and not a better service to the patient that could be provided if things were resourced properly. Now, I accept the limitations on resources, because we will find time and time again that it's difficult to attract resources into our part of the country, and indeed there's a waiting list for professional staff that seems to be impossible to actually fill. I didn't think an awful lot to the options that were under consideration, because it seemed to me that the options were designed to lead the consultation into the direction that is being promoted. And indeed, with the limitations on resources, be they physical or structural, it probably is the only option that's available to us. But it should be marked as best that we can do, rather than a better way of doing things.
I don't know if you'd like to come back on that, on any of the points that has been raised by Councillor Allen at all.
I think it was sort of made as a comment back, and I think that's fine. We'll note that comment as well. And we did, obviously, I outlined in the original slide. Obviously, there are some significant challenges that we've had to look at around that as well. So,
thank you, Councillor Bunny.
Thank you, Chair. My main question comes around consultation in the Gainsborough area and the western side of West Lindsey. I appreciate that you have made some changes to the consultation process since we met on this October the 17th. But my concern is if we're going to put them in on December the 4th, how are we going, or the week beginning the December 4th, how are we going to get that information out amongst the population? Certainly, talking to local members at the district council and the town council in those areas, they were unaware that this whole process was taking place. And as we've heard about the previously, when the whole of the district was given a letter, I'm not sure we can do that now, but I just want to make sure that it's not too much of a hurried last-minute process. Those of you will know that West Lindsey have been involved with quite a lot of work at Scampton, and there the Home Office were putting in consultation meetings within less than a week. And if it's something like that, people can't always get there and can't get through, and that does worry me. The second point, I'm glad to see also that the transport section has been picked up, because that does need to be looked at, and it's obviously, as you say, not just the ambulance or the admittance there, it is actually getting people across to the hospitals, to loved ones and families and so on, which is not an easy process if you live in the Gainsborough area and rely on public transport. My last point, and I know really is a bit off this in a way, but part of the original scheme we had was looking at the opportunity to have virtual wards, a bit more work being done from homes and so on, and on over the line. We in an area have very poor spots of communication, and I do hope that that is borne in mind, that it isn't always easy to get onto Wi-Fi, it's not easy to get onto broadband services in some of our rural areas, and that does cause problems when it comes to providing services in that manner.
Shall I just pick up the last one? I think three really helpful points. Thank you very much. Certainly in terms of one thing we haven't particularly talked about here is there's a parallel piece of work going on looking at out of hospital services. So you alluded to the virtual wards. That's something that we are looking at, but we also look at a whole range of out of hospital services, community response, to response, etc. Because to enable these changes to happen effectively, we're very cognizant that we need to make sure we're continuing to develop and strengthen our out-of-hospital services to be able to respond to that as well. So we do have a completely parallel piece of work going on to understand implications of any of these changes around the community and what we need to do to be able to strengthen that as well. And your point about the digital component of that as well is noted, because again, it's a much better option for people if we can try and support them close to home as well, and get people home as quickly as we can. It's good to hear the positive comments in relation to transport, so we'll continue to drive that. We see that as a key important piece of work supporting this as well. And then just on your point about communication, probably just bring Lindsay in on that one, just in terms of making sure that we get the messages out around the work, what we're planning to do in Gainsborough as much as extensively as we can, so we can get as good an input from local people around that as well.
Thank you, Alex. Yeah, and I think just to come back around the questions about advertising, I think that was one of the key reasons I wanted to have all those dates firmed up before this meeting. We are using all of the connections that we have as a system, but obviously we predominantly work in the north end of the patch, and not obviously our patients come in from Lincolnshire County, but we are relying on working with colleagues in our neighbouring ICBs to help to spread the word through their networks into as well as the ones that we have existing. We obviously will use local media as much as possible, and that has been quite beneficial in terms of getting people to know about the consultation and to know about the events. But again, as I've said, I think in one of the previous questions, any support that members of this committee can give, any support that local authority can give in terms of getting the word out about the consultation would be really, really, really welcome. For example, we've worked with North Lincolnshire Council, and they have put an article in their magazine that goes to every household in North Lincolnshire. Any opportunity to do something similar across West Lindsey, East Lindsey and other areas would be really, really welcome.
Okay, thank you. I'm just going to build on from what Councillor Bunny was saying. Having seen throughout the document that there is mention of a transport action plan, when can this actually be shared? Because as we know, there are pockets of deprivation throughout Lincolnshire, often meaning people can't afford a car. We also have issues with public transport in such a rural county as ours. and this will potentially have a serious impact on those travelling further and the ability of their loved ones to visit. Personally, I feel currently there is not enough contained within this consultation to mitigate these concerns, and it worries me that we're being asked to make decisions moving forwards without all the information.
Thank you, Chair. If I just pick that up, and maybe colleagues might want to jump in as well. So the high level transport action plan, so the key themes that were co-produced with partners are is included within the pre-consultation business case, which was shared with the Joint Scrutiny Committee, and it's available on the website for anybody who wants to read the whole business case or any individual part of it. And what that gave us was some themes and key actions, so specific areas to look at in terms of transport. And that the Transport Working Group met for the first, met together as a large group during consultation on Monday. Unfortunately, I wasn't able to attend because I was in another engagement session, but that did include colleagues from local authorities and the Trust, the ICB, but also from wider partners as well. So we had public transport representation there as well from the commercial bodies who run public transport, and they do have some developing ideas coming out through that group, but obviously we need to develop them during and following the consultation, because what we don't know at this point is what the specific changes will be. We have a proposal, but it's still a proposal for consultation, and it's still subject to that decision making. So what actually comes out the other end may not look exactly the same as what was in at the outset. So it will be an evolving piece of work in terms of those transport solutions. And one of the key things that we are hearing through the consultation, through the in-depth detailed discussions we're having with people is ideas and suggestions in terms of what things could mitigate the impact, and that will enable us to put those ideas and suggestions into the transport solutions that come out the other end. So it will be iterative, and we can't give the definitive answers at this stage because we don't have a definitive decision. But we are continuing to engage with people both through the consultation and through that transport working group. But I did hear positive things from the meeting on Monday, so suggestions and ideas that are being developed and taken forward.
Okay, thank you. Councillor Smith.
Thank you, Chairman. Before I ask my question, the last point doesn't really answer your question, and I know you and Councillor Bunny and myself have read that document from one end to the other, and it's quite substantial, and it certainly doesn't put to rest any concerns I've got, or I know you've got, and I'm sure Councillor Bunny is the same, and certainly on transport. I'm going to build on a point Councillor Bunny and you've raised already, Chairman. There is this, and this is not just a North East Lincolnshire thing, this is across the whole NHS, there is this this drive, and why there is this drive that, oh, disabled people, we all want appointments by phone. When they work, great, but if you've got, say, my condition, which is cerebral palsy, oh, we'll assess you over the phone. Well, unless you can see my legs and how I'm walking, that's about as much use as a chocolate fire guard. And there is I have this real concern, and this is not just a North East Lincolnshire issue, this is the same for Lincolnshire, where, and I understand wanting to do things close to home, I would love to be able to have, say, my assessments on a video call where they can see me if I didn't have to travel, and I thought it would work as well. But frankly, Chairman, they don't. To get the best possible, in my case, and I'm sure it's similar for others with my condition, I can't speak for any other conditions because I don't have them, you need to see somebody in a hospital environment where they can see you, where they've got, if you need to go for an x-ray, you need to do whatever you need to do after they've seen you, you have to be in that environment. And the reason they don't want that, Chairman, is unfortunately, that costs money. Well, it's going to cost more money if we try and do it on the cheap, and then we get comorbidity problems because, unfortunately, much like veterans, people with disabilities who you're trying to make things, quote, easier for, have comorbidities usually, or multiple problems, one impacts the other. And trying to make it easier, you're actually making it harder because more often than not, they acknowledge, yes, it's financially difficult, yes, it's a problem, yes, it's time-consuming, but actually, most disabled people I've spoken to actually want to see somebody in the flesh and say, this is the problem, this is what it looks like, what can you do? Now, there may be instances where you can't do anything, and, you know, my condition is pretty much is on that sort of phase at the moment. There's very little you can do, it is what it is. But I still want to go and see my consultant and my specialist who I see, because he might see something from seeing me, oh, have we tried X? You can't do that over the phone, Chairman, and we really need to get away from this be all and end all of everything needs to be done over a phone. Everything needs an internet connection to be done, because actually a lot of patients, myself included, do not mind travelling if we actually see somebody face to face in an environment where we think we'll get the best care. And actually, this needs to be a listening exercise to patients, where if a patient says to you, this is not going to work, it's usually because they've tried this before and it doesn't work. And we need to start listening to patients. Yes, I know there's a cost implication and there's an inconvenience implication, but if a patient is willing to accept the inconvenience, we shouldn't be met with a brick wall to go, no, it's over the phone. No, it's this. And I've had that recently in Lincolnshire, Chairman. I had 2 phone appointments and I couldn't make a physical appointment. And then I had to explain on 2 occasions, no, I want to see somebody, because this is not going to be a 5-minute phone conversation. My phone signal is appalling, so you're not going to be able to hear what I'm going to say to you anyway. I need to show you what my problem is so you can understand the problem. And that took about 6 months, Chairman. Now, I don't mind waiting longer for an appointment, and most people are the same, but we need to get away from this. Everything must be out of a hospital environment. Everything must be a digital solution, because, as you've already said, Chairman, in Lincolnshire there are vast areas where mobile phone signal, internet connectivity does not allow for that. And to assume one size fits all, which is what seems to be happening across the piece, as I say, it's not just a North Lincolnshire issue, it's an issue here as well. We need to really get away from and start actually listening to patients, which is what the NHS should do, because actually we might not know the medical reason, but we know our own bodies better than anybody else does because we live with them. So it's about a bit of give and take from clinical staff and ourselves, and understanding where we can meet in the middle, because at the minute, Chairman, that's not happening. And as you said, I don't think there's enough information, and I think this fascination with doing everything virtually or at distance is going to have real health implications for a lot of people, and it's going to be very harmful long term if we get this wrong.
Shall I just start, and then I'll probably bring Anwar in if that's okay. So I absolutely agree. This is a mixed economy, because for some people, the ability to, if it seems a relatively straightforward, the ability to actually do that remotely or non-face, I think has been a real benefit. So we've all heard the example, haven't we, where people have had to travel to a hospital, go through the trauma of trying to park, get into the hospital, to be told by someone, oh yeah, we've got your blood results and they're fine. And that could have been something really straightforward and simple. It could have been done over the phone. So I absolutely take on board your point. This absolutely does need mixed economy, and nothing we're putting in these proposals suggests that isn't the case, where we have the ability to look at the options for virtual non-face-to-face appointments, but we do that alongside the ability to be able to access face-to-face appointments, because, as you say, that is absolutely clinically appropriate in certain situations. So I think there's a clear desire to continue to support a mixed economy for doing that, but I believe there is a place for both of these, because for some simple and straightforward things, then non-face-to-face is really valuable and does present a better option for some people where it isn't necessarily necessary to go. So it's got to be based on the individual, hasn't it, and looking at their holistic needs as well. But we'll just I'll just bring in Anwar as well, just in terms of the clinical side.
Thank you. Thanks, Chair. And thanks, Councillor. I think 2 things really. One is that obviously this consultation is about the urgent emergency care side of it and not outpatients and appointments, and we are not proposing any changes to that. What happens in urgent emergency care at times is that you need specialty advice for a patient who's ill and in your hospital site, and you aren't able to transfer the patient in time to get that opinion. And that's when the teleconsultation helps and helps you make that decision earlier, even to say that actually, yes, this patient needs to come across to the tertiary center to be looked after by us. So that's where we are putting in the teleconsultation bit, is that because let's look at it. So currently there is no cardiology on the weekend. And if somebody gets very sick on the Scunthorpe site or on Grimsby site on the weekend, as a cardiology patient, we don't have the skill mix to manage that locally. So we are then dependent upon Castle Hill. So we phone up Castle Hill and they may have a bed or may not have bed. On the basis that they advise us what to do and what not to do. Now, if we have technology, then at least they can look at images, they can look at their ECGs, and they can advise us to say, by the way, in your monitored bed, give this treatment and we're happy with that, and we'll remotely monitor. Those are the kind of things that will help. And that's the reason why we want to, some of these specialties, we want to centralize, because what we want to do is have somebody who's a specialist present 7 days. Now, no matter how much money we put into that, the area we live in, we're not going to get the staff. So the staff, the number of staff that we have and the skill set we have, we need to keep their skill set as well. To keep their skill set, they need to have certain number of people seen in the year. So if they don't see that number, then we will not revalidate them and they will not keep the skill. It's the best example for that is the stroke consolidation. We did that because we were seeing, as a system, we were seeing about 550 to 600 strokes a year. Now you split them into 2 services. It's not enough numbers for the stroke team to keep the skills. It had to be centralized, because then the whole team sees the numbers, that they keep the skills, but also the benefit for the patient is that they get looked after by people who are more experienced and keep that experience year on to be able to look after those patients, rather than people who keep losing that skill because they don't see that many numbers. And that's the problem we have with all specialities, is that the expert needs to see that many number in a year to keep his or her specialist skills. Now, to have all those people in a rota that works, some of these services need to run from one side for that to happen. And that, obviously, yes, we are limited by resources, and we would plan based on state resource, number of our professionals resource. But that's a bit. So teleconsult actually sometimes saves lives in certain situations. In other situations, I'll give you an example. If the ambulance crew had a ability to teleconsult with a specialist or a clinician who's an expert in the hospital, they may not need to bring the patient to the hospital. And that's the other bit that is important. That should happen, is that not everybody needs to come to hospital. Similarly, not all outpatient settings need to be in the hospital. They can be in the diagnostic hub that, we're developing big diagnostic hubs, particularly for Scunthorpe. So the specialist could come and sit there and do the clinic, because they'll have that time to come and do it. So the other beauty of centralizing things, some of them, is not everything, is that then on the other side or in community, some of the people who are not doing that ward work or the inpatient work during that week are actually freed up to provide that. So somebody can then travel and do a remote clinic. So a cardiologist who is a specialist can come and do a clinic in the diagnostic hub in Scunthorpe and see the patients face to face that they need to see. That's the bit that we are trying to get better.
Very briefly, Councillor Smith.
Thank you, Chairman. It is brief. All I'll say is that when you read that in the consultation, that is not how that comes across. I fully accept for yourselves as clinicians, it absolutely makes perfect sense for that system to be in situ, but that is not what the consultation, the way that reads. The way that reads to me is that is impacting patients and individuals more than for yourselves. And all I'll end on very briefly, Chairman, is we are growing. We are not shrinking in terms of the number of houses we are expected to take. And the same will be for North and North East Lincolnshire. So my concern is, I accept what you're saying around the number of professionals, but we're going to get to a tipping point, probably in the very near future, where we may need 2 hospitals again. And when they're gone, building a new one's expensive, Chairman, as we know, and that, never mind just adding to a hospital. So we need to make sure, Chairman, we as politicians and yourselves as clinicians, that this is going to be a workable solution, not just for the next 5-10 years, but for the next 30 to 50 years. And I can't see it being, I'm sorry to say, I can't see it. I'd be very surprised if this is in the same state it's in within 10 years' time. And I'll leave it there, Chairman, and thank you for your indulgence.
Thank you. I have now 3 speakers. I'm closing the debate down because I'm conscious of time. I've got Liz Ball first, please.
Thank you, Chairman. You'll be pleased to know my point is quite short, but thank you very much, colleagues, for your presentation. From a Health Watch perspective, it was really a offer of support, particularly around the events that you're planning for Gainsborough and Louth, and building on Councillor Bunny's comments. If you link with us, we can probably provide you with a lot of patient group and networks, veterans groups, etc. So we'll have all those contact details. So happy to give Katrina details of who to make contact with, and hopefully that will support those areas. Thank you.
Thank you, that's really helpful.
Okay, thank you. In which case, I've now got Councillor Mackinson-Saunders.
Thank you, Mr. Chairman. It's really good news to hear that if you have a heart attack on the Friday afternoon, you're not going to be doomed. Health is a 7-day-a-week issue, and if we can consolidate services, so much the better. I was going to check on the date you said you were coming to Louth, because you did say the 29th of October, and I assume you meant the 29th of November. If you could just confirm that.
I did, yes.
Yeah,
yeah.
Is that morning or afternoon, please?
It's the middle of the day. I'm told there's a Christmas concert in the library. So we're going to be there. I haven't got the exact times, but probably from 11 till 1.
11 to 1, thank you. And lastly, I do have some experience of strokes. My mother was in Lincoln Hospital for getting on for 6 months, and I did drive daily to Lincoln to be with her. Unfortunately now, I think the ambulance takes you to where they want to take you. You don't have a choice of where you go to. And getting to Scunthorpe to go and see somebody in hospital is particularly difficult. There isn't an easy way. You can only go by car. You can't go on public transport. Well, it'd be really convoluted in public transport. And if you came from Mablethorpe and you were taken to Scunthorpe, it'd be even worse. You'd probably take a whole day to get there, I should think. But I was interested to know what the step-down services were. Do you then repatriate to something like Archer Ward at Louth, or do they have to go into a nursing home after that? How does the system work once you've got them over in Scunthorpe? Because I'm not convinced that Scunthorpe computers actually speak to the ones that we've got in our neck of the woods anyway. But what is the... Sorry.
I'll come in, Chair, if allowed.
Could you explain how that works, please?
So stroke services, obviously, over the whole country, so for example, I'll give you an example for London, 32 centres to begin with. Now they're 8. And they're reducing down to 4 because now there's a development in stroke, which is to provide a catheter and go and get the clot out, which is thrombectomy. So some patients are suitable for that, some are not. They are suitable for the drug that we give that dissolves the clot. So all patients that have a stroke need to come to that service where that clot busting, where a CT scan can happen immediately and that clot busting drug is available, which is why the centers have been reduced in number, because all hospitals used to provide that at some point, and then now they've reduced. And over the whole of our ICB, we've actually got 3 centers. So patient comes to that with ambulance, reaches that, we do the scan within the hour, we do the drug in patients who require it. Patients who completely improve will go home. The patients who have some recovery, but they still have therapy need, will go to a local rehabilitation facility. Now for Grimsby, what we tend to do is we transfer them back to Grimsby, where it used to be the stroke ward, which is C7. And then from that, there's another facility, which is Cambridge Park, which is a rehab facility in Grimsby. Similarly, at Scunthorpe, we go to Sir John Mason. For Gould patients, we will get them to Gould Ward 3, which is also a rehab facility. And any community rehab that's required. Some of the patients will go home with rehabilitation, and then the community physio and the community OT with some care will be providing them that at home. So there's a variety of patients, how the outcome happens. So if somebody is completely dependent and they require feeding tube, then they stay with us for a bit, and then we try to move them to their local hospital or their local facility where an NG feed can be continued. Now, Louth sometimes does it, sometimes doesn't. And then we are dependent on Lincoln Hospital to get them across to Lincoln to say, because they require inpatient NG feed till they get the PEG tube in, which is the stomach tube. And normally that period is about 2 to 3 weeks before they get that, because we need to give them a chance to see some of them actually recover the swallow, and then you take the tube out and they are able to swallow. So there's a variety of things that happen, but as soon as we've done with the acute bit, we try to repatriate them back locally. And same system will be in place for cardiology, in fact, for if we do this.
Thank you for the explanation.
Thank you. I've got Councillor Bunny.
Thank you, Chair. I was just going to pursue something on waiting times, but I'm quite happy to do that in writing at another time.
Thank you, Councillor Bunny, in which case I've just got 2 questions myself, and then I'm going to move to a proposal. So my first question is, what so far has been the response of those members of staff who now potentially will have to travel further or find another job with another trust closer to home under these plans?
So can I come into that? So there's obviously different type of staff that we have. So we have clinicians, then we have nursing staff, and then we have the ancillary staff that help us around. Now, the potential for travel and changing their job plans is mostly going to be the clinicians, and less impact on nursing staff and the other staff that helps around the hospital. So the clinicians are undergoing workshops at the moment. You'd be surprised to know that over now, last 4 years post-COVID, we started to integrate between the 2 sites anyway. So acute physicians who actually are at the front door and are going to be the ones that will remain on site actually do have rotas that work across. So I work 2 days in Grimsby and 3 days in Scunthorpe. I used to only work in Scunthorpe 5 days. Because we want to have the same pathways on both sides anyway. So that's just the front door, and emergency medicine people also work across site. Now we're making appointments. Now the next bit, the ones that we want to, the specialties that we want to or propose to centralize is mainly orthopedics, general surgery, and cardiology, respiratory, and gastro. Gastroenterology, respiratory already work cross-site. And in fact, gastroenterology, because of lack of a clinician, we've turned that ward into a general medical ward anyway. So they do provide 5 days gastroenterology input at Scunthorpe already in that fashion. So there are already bridges being made, and people are going across to the other side working. Similarly, the other way around is also happening. So some of the cardiology people from Hull are coming to work in Grimsby. Some cardiology clinicians are coming to Scunthorpe to do procedures and do outpatients and work in Scunthorpe. So that bit of work has already been happening for a while because we needed to keep the skills, and we sometimes, because of covering rota, we had to move people around to cover rotas. So people now got used to working on both sides anyway. Yeah, there will be less movement of nursing staff because they are mostly facility based. So that's going to be less impact. It will impact some specialist nurses in cardiology, for example. But you see, what we do have and will have is level 1 or monitored beds on the Scunthorpe site anyway for anybody that's sick. So that skill will be utilized there. So that's where we are with the staff, and we're undergoing multiple workshops with every specialty at the moment to go through, because obviously it's a proposal. We need to see their viewpoints. We did that at the beginning, but we now need to do it with this single proposal.
Okay, thank you. My final question is, in July it was announced that maternity services and neonatal services have been decoupled from the programme. Do you know what the timescales are for developing proposals for these services, please?
Thank you. We don't have a formal time scale around that, but we will be doing a further piece of work to look at the maternity and neonatal services, but not just in terms of the Northern Lincolnshire footprint, but looking more broadly at the implications across the wider footprint. So as soon as we've got a timeline, then obviously we'll share and engage around that as well.
That'd be useful, thank you. In which case, I'm going to move to a proposal, and I propose that the Humber and Lincolnshire Joint Health Overview and Scrutiny Committee's role as the statutory consultee on the Humber Acute Services Review for the purposes of Local Authority, Public Health and Wellbeing Boards and Health Scrutiny Regulations 2013 be noted, and that the committee make a response to the consultation as a non-statutory consultee. And thirdly, that a response be drafted on the basis of the comments made at this meeting and be submitted to the committee's next meeting on the 6th of December 2023 for consideration and approval. And finally, that this committee's own response to the consultation be shared with the Humber and Lincolnshire Joint Health Overview and Scrutiny Committee with a view to it being considered for inclusion in the Joint Committee's response. Do I have a seconder to my proposal? Thank you, Councillor Lundwatton. Okay, all those in favour, please show. That's supported unanimously. Thank you. And thank you to our presenters for attending today. We appreciate it. Thank you very much.
Thank you very much. Thank you.
Thank you very much. Bye.
Bye. We'll now move straight into agenda item 6, the Lincolnshire Acute Services Review, Orthopaedics and Stroke Services. The item was circulated as part of the agenda pack on pages 51 to 57. This item focuses on 2 services from the Acute Services Review. I remind the committee that the other 2 elements of the Acute Services Review, urgent and emergency care and medical beds at Grantham Hospital, were considered in July. I'd like to welcome our presenters via Teams. Pete Burnett, Director of Strategic Planning, Integration and Partnerships, NHS Lincolnshire's Integrated Care Board, and from United Lincolnshire's Hospitals NHS Trust, Dr. Samida Reach Mahadev, Director of Improvement and Integration, Carl Ratcliffe, Managing Director for Medicine Division, Velka Sievel, Consultant Orthopaedic Surgeon and Divisional Clinical Director. If there are others there with you, I apologise, but I can't see the screen. So I'll hand over to you. If you could do the report in about 10 minutes and take questions at the end, please. Thank you.
Yeah, thanks, Joe. I'll do a brief introduction, then I'll hand over to Val and Sarita. Just to note that Carl can join us today, so Rebecca Johnson has joined us on the stroke development as well. So just very quickly, just so everyone's up to date, obviously the acute service review's been going on for some time. Previously to the ICB, when the CCGs were around, the CCG led the public consultation on the 4 service changes. That was agreed through decision-making process in May 2022, and we're back here now to talk about the progress in both the orthopaedic service since that business case was agreed, and then also the stroke services going through. So I'll hand over to colleagues not to take up too much time, but the orthopaedics was to consolidate planned orthopaedic care at Grantham Hospital, with day case taking place also at Louth Hospital, and the stroke service consolidate stroke services at Lincoln County Hospital, but with an integrated model with the community stroke teams to ensure rehabilitation took place out in the community. So I'll hand over first to Belle to give an update on the orthopaedic side, and I think then it will be over to Samida around stroke. Thanks. Belle?
Thanks, Pete. Thank you. Hope you guys can hear me. I'm Bell's active orthopedic consultant and clinical director for surgery division. We have reconfigured services and split elective and hot activity across the county, and we've been doing this for the last 5 years, where initially it was a pilot, and then we went through the acute services review, and this was passed from that review. Essentially, we do planned operating, orthopedic operating at Grantham, inpatient service, and day service happens at Louth, whereas the hot activity, by and large, happens on the Lincoln and the Pilgrim site. This has helped us a lot because we have reduced cancellations due to lack of beds from elective services. We have been managed to get into the top, certainly top centile for in the country for length of stay. We are able to specialize services. We are able to provide higher specialized services like day case, arthroplasty, joint replacement services. our RTT performance has improved, and most importantly, what we've realized more recently is we've been able to provide mutual aid to our neighboring trusts when they have been struggling with their performance, especially after COVID backlog. Certainly, people have been traveling from as far as Stoke-on-Trent to come and have their services surgery at Grantham. So that is all is a good success story for us. We have added some patient feedback as well in the report. I'm not going to go through all of that. You can read the report. Also, from a post-op review point of view, we found that we only had to transfer 3 patients over a large time period to our hot sites who required more higher specialized post-operative care, which is extremely good considering that in the first sort of 8 months of this year, we've done about nearly 1,150 patients. So that is still a promising. We have a backup service for post-op review and post-op management of post-op problems. And we have not had any problems for patients, or rather not problems. We have not had any cancellations of the operating regarding to travel from our patients within the county, is what I would like to add, and which is all in the report. And obviously, I'll be happy to take any questions and clarify any further points. Thank you. All back to Pete. Thanks.
Yeah, Sam, you can provide the update on Street.
Yeah, thank you. So colleagues, thank you for having us today. I'm Samida Rich-Mahadkar, Director of Improvement and Integration here and the exec sponsor for the stroke service. As we know, we've been on this journey with the stroke service, so to have the single Lincolnshire stroke service, and as part of that, we've been also having plans around the estates development at Lincoln County Hospital. We've set up a joint stroke board. So this is with our community partners alongside Stroke Association and other key partners, just to work out what is the key process and what's the key model that we all need to be working towards. So the last few months, the teams have had a number of workshops, bringing people together and really getting into the nub of what is it that we need to do to improve the stroke pathway, what's causing the delays, how are we going to improve the service and really bring the length of stay down for our patients. Unfortunately, due to the fragility of the service, we've had a couple of our locum consultants sort of leave, in which case we had to accelerate some of our plans in the whole timeline of getting the single service together. So from 4th of September, all new patients suffering a stroke in the county and needing acute specialist care, including acute stroke rehab, are taken to Lincoln County now. However, we've still kept and maintained the outpatient appointments linked to the stroke service at Pilgrim Hospital, including the TIA clinics each week. So really, really keen that we ensure our patients get the best service possible. The team continue to work towards the ambition of a 10-day length of stay. And again, Rebecca Johnson from my team has joined us as well, who's leading the excellent work around the business case development. So they've been around the country looking at other cases of what other hospitals have done. And as part of our capital development, we've successfully secured £3 million as well in order to add additional beds at Lincoln County to be able to sort of develop our service further. So I'll pause there, councillors. Happy to take any questions. Thank you.
Okay, thank you. Councillor Holland then, please.
Thank you, Chairman. Thank you very much for the presentation. The paper does suggest that orthopaedics is performing very well, strokes perhaps less so. I would just like to ask a question about performance. The performance is very much targeted about the actual event itself within the overall orthopaedic story, I suppose. One of the patients was saying she'd waited 4 years, but she was very happy once she had the operation. That is very, very good. But performance and indeed referrals times do seem to be going down, and length of stays do seem to be going down. But in overall performance terms, and in the overall situation that we have within National Health with the waiting list, does this mean that we are getting more procedures through the system? Because that's what I think is quite important from a performance point of view, is the output of the National Health Service, or in this particular place, the Grantham facility, actually dealing with more patients.
Feel free to come
chamber.
in. To be fair, I can't always see you on the screen because it sort of jumps between in here and obviously what's on there. So yeah, just feel free to come back with any of the questions.
Thanks.
You're
Val,
on
you're on
mute.
mute.
Sorry. It's actually a good question because that's something what we regularly talk in our meetings to see, does our improved performance actually filter down to the patients, as it were. I can tell you and reassure you as a group, this does happen. So before the reconfiguration, for example, we used to average about 2.5 joins a day is operating. Now we do 4 joins as a default. Yes, admittedly, 1 or 2 lists. We have 3, but by and large, we have 4 joints. This is a equivalent of a hip or a knee replacement. And we compare other operations in terms of times to this operation because this is almost standardized in terms of time. So yes, it has improved. We also are able to provide more operating on the weekends, which we did until January, then we had to pause. But now we've restarted weekend operating at Grantham, so we're getting more patients through that. As I told before, we are giving mutual aid to other people who are waiting longer than our population within Lincolnshire. So by and large, this is helpful for both closer to us and slightly wider apart as well.
Okay, Councillor Smith.
Thank you, Chairman. 2 points, if I may. With regards to stroke services, what's being done on the recruitment front, and if you were to secure additional staff, would you reopen stroke services at Pilgrim? And I'll follow that on with the question I asked the Chairman with regards to his announcements at point 4, which is the concerns of a whistleblower with regards to the loss of the acute stroke unit at Pilgrim. This is a concern that we have expressed ourselves as a scrutiny committee. And my question with regards to that is what investigations are being done into those concerns, because for somebody to whistleblow on something like that, they must have very serious concerns, because ultimately, whatever anybody says, their job is now at risk, even though it shouldn't be. And we know what happens to whistleblowers, unfortunately, and it shouldn't. So what investigations are being done in that regard as well? Thank you.
Thank you for that question. So to put it a bit into context, there have been lots of staff communication about the long-term view of stroke and what's going to be there. As Peter described to us earlier, as part of the acute services review, this was the journey of having a single stroke service. We've done proper staff consultation as well. That's been through our joint negotiating forum since July. So in terms of whistleblowing, staff were aware of the changes. Clearly, there are still staff consultations in terms of jobs and what happens next, not taking away from the fact in order to have a very successful single stroke service, we need to get the therapy aspect of the stroke service strong. And that's what we are working with our community trust. In response to your other question around, will we open Pilgrim again if we got more additional consultants? I think we will focus on making our current service much stronger because it's still fragile with a single-handed consultant. We're investing more in Lincoln with getting more 7 beds. And of course, you know, everything's on the cards for getting the right service and the right sustainability in the future for the service. Peter, did you want to come in?
Yeah, it was just on the question of open up. The consolidation was to improve patient care. If you look at a strong stroke service should see over 650 patients a year. Lincoln County already saw that. Boston, even projected growth, wouldn't grow in terms of the timelines. We're over a 5-year period to have that level of strokes being presented at Boston Hospital. So even in its own right, even if you had the staff, they would be down skilled by not doing the procedures on a regular basis. So the reason we consolidated is to there are staffing. There's a national staffing shortage. I saw that as we joined the back end of the previous presentation. But B, you need competent staff who are practicing stroke care on a daily basis at the right level of kind of procedures taking place, and that's why it's consolidated Lincoln. There's also the onward referral pathways around mechanical thrombectomy, which are into Nottingham University hospitals. So that makes sense in that regard, because actually from Boston it was either into Nottingham itself or it would be into Cambridgeshire, and the evidence showed actually they're less likely to be referred the further they are away, and then miss out on that procedure because of the timelines to get there. So I don't think it's just around the staffing to consolidate. It's also a matter of stroke presentations. So as Samida said, concentrating on the Lincoln site, growing the model there and strengthening the capacity that we have on that site. And then the integrated rehab is the key piece to this, because the aim is to obviously get patients back to their pre-stroke selves as soon as we possibly can, or as close to that pre-stroke self as we possibly can, depending on their kind of stroke condition.
And
Sorry,
also the stroke, the consolidation of stroke services also follows the National Strategy for Stroke Services and also follows our Integrated Stroke Delivery Network, which is our regional aspirations. And this follows kind of the national aspirations about centralisation of the service, improves patient outcomes and also patient safety. Thank you.
Thank you. You've very thoroughly answered my first question. With regards to the second question, is any investigation being done? Because, as I said, for somebody to actually whistleblow on something is huge. And it obviously it's echoed concerns we had as a committee when this was brought. So it's just to try and flesh that out if you can. If you can't, because it's an ongoing investigation, I fully understand and appreciate that.
Yeah, no, thank you for that, Councillor. I take that away and I'll come up with a thorough answer, just because I don't want to give away something if there's an investigation going on. So if that's all right with the committee, I can answer the question sort of outside and supply the response back. Thank you.
Thank you. I've got no one else indicated to speak. Oh, Councillor Makinson Saunders.
Thank you. Well, I've got personal experience of the stroke unit at Lincoln. My mother had a stroke in teens of years ago, and the service did need improving, and she spent the rest of her life paralysed and lived for 13.5 years. And I'm very sad that the service was so poor in those days, and I'm really glad and heartened to see that we are addressing that, because it's a horrible way to live the autumn of your life. So, you know, more power to you.
Thank you. In which case, I've got a number of questions. So my first is, how resilient is the elective orthopaedic service in the face of winter pressures and the pressure to reallocate resources? For example, are as many patients likely to be treated in January as in July? And what effect is the national industrial action having on this service?
Thank you, Chair. First question is, we believe it's very resilient as we stand. At the moment, the whole aim of producing or choosing or being elected as a hub, as an elective hub nationally, for people who are not aware, this is an elective hub accreditation program for the whole country, and Grantham was picked as one of the first 8 as a pilot, and we were successful in being accredited. One of the main parameters for being an elective hub is that we do not, we have ring-fenced elective resources for elective activity. Hence, we would not be impeding on hot or winter pressures within the elective service. I'm not sitting here and saying never, but it's going to be close to 0%. Clearly, we will put patient safety as our prime reason, and if we have to take, and then the board will take a decision on that. But essentially, I'm not expecting any winter pressures to vastly influence that. And I believe it to be very resilient towards the winter. And the short answer to your question of will the same number of patients be treated in winter as opposed to summer, is the short answer is yes. We expect that to happen. The other question about, sorry, what was the other question, Chair? I missed that.
Just on the impact of industrial action.
Oh, yes. Yeah, thank you. So, yes, well, it's far be for me to say that we are not impacted with industrial action. We have been. We were doing very well in terms of getting up to speed with the waiting lists and things, but it had to just take another sort of dip following industrial action. As I said, one of the reasons why we wanted to open up winter weekend operating was exactly that, to catch up on our backlogs and things. And we've just started that going for a few weeks. We have been doing that. So yes, we have been impacted, but we are addressing it. Samida?
And if I may come, Chair, on the industrial action note, it has impacted us. we always have really difficult dialogues with our consultant colleagues who I understand the reasons why they're having an industrial action, but we always keep pushing for there's a patient at the end of this. We cannot cancel our elective list. We cannot take down anything. So if you look at our plans, right to the very end of the moment is when we start pulling things down. So right till the very last minute, as far as possible, we try and run a list. And the second point on industrial action as well, and our backlogs. We've got a dedicated improvement program looking at productivity and improvement for our waiting lists. So again, we're really keen that patients don't wait long for their procedures. So we take sort of a very detailed approach looking at data and analysis, and we go to each specialty to say, right, what are you doing about your backlogs? How can we support you to get this over the line? Thank you.
Thank you for that. My next question is, what is the extent of the impact on Lincoln County A&E since the 4th of September when all stroke patients have been taken there?
Am I able to come in on that one? So the centralisation of the stroke units has happened for hyperacute patients. So they're the patients that come in through ED since 2020. And so what we've been able to do since that time is make sure that we've got a robust ACP workforce. So they're able to meet the patient at the front door and then commence with the diagnostics so that we're able to treat patients as quickly as possible to then improve their patient outcomes. So we have been managing patients coming to ED since April 2020. So this is something that we've been improving on and working on since then.
Okay, thank you. The next question is, with the closure of the stroke ward in Boston Pilgrim, how many dedicated stroke beds are currently available, and can anything be done on a temporary basis before the new unit is now constructed?
If I can come back on that one. So what we have, so we've closed the beds over at Boston. What we were currently utilising over the last 2 months was on average 6 beds on the Boston unit. So what we have done on the Lincoln site is we've been able to consolidate some beds together so that we're able to have the stroke unit, which has got 28 beds, and also there are 8 beds on Burton ward, so that we can then keep our outliers together and ensure that we're able to have the increased and kind of improved patient safety, as well as patients which are together, so that we can then make better use of the resources that we've got.
Okay, thank you. And has the centralisation and alteration of these services led to an improvement on recruitment and retention as expected? And if so, can you expand on this?
So we're still in a process of with our recruitment drive, because we're not able to fully have the build on board. So our build is meant to be completed by September, or to commence September 2024. And what we're hoping is that then we're able to build on that. What we have done is we've been able to recruit further ACPs, which then has given us some more stability to our workforce. And we've also been able to recruit an additional consultant, which started in September, and that has kind of further made our service a lot more robust. But there are then those aspirations as we then progress to then further do that. Samida, do you want to come in? Sorry.
Yeah, just building on that. So from a fragility perspective, we're actively working with other acute trusts within the East Midlands as well. Just as we heard from Acute Humber, this is a national problem. So we're actually saying collectively, what can we do differently to attract more stroke consultants to East Midlands as a whole and share the resource in terms of rotation as well. From a therapy aspect, again, we are out to recruit, still early days, but we are trying to get sort of a really strong and stable stroke service. Val, do you want to come in on that as well? Thank you.
Thanks, Samida. I can give you answer the question from an orthopedic perspective, and seeing that orthopedics has been a few years ahead of the curve in relation to stroke, maybe those are the learnings we can have for both. In orthopedics, it has improved our recruitment. We used to have what we would term as middle tier surgeons who are in the process of being trained. Now following this, we have now recruited to fellows who are like senior clinical fellows who are pre-consultant levels, who can operate independently, but just want that minor tweaking before they take up consultant roles. We are able to do that. We are able to recruit into more middle tier doctors who are career oriented, who are career focused. We have a challenge with the junior force, but that's not necessarily related to Grantham as such, but that's more based on the Lincoln and the Grantham and the Lincoln and the Pilgrim site. But generally speaking, we have enjoyed a better recruitment drive after we reconfigured within orthopedics. Thank you.
Okay, thank you. And my very final question is, what is a medical outlier as your final page 56 in the final paragraph, please?
Yeah, I'll come in there. So a medical outlier is a patient that isn't situated on the ward. So, for example, a stroke medical outlier is a patient that's not on a stroke unit. So what we're doing within the stroke services is putting our medical outliers together onto one ward so that we don't have them based on lots of different medical wards. They will be on a specific medical ward so that we're able then to have stroke nurses, stroke therapies and stroke consultants there as well.
Thank you for that, in which case I'm now going to move to the proposal, and I propose that the presenters from the NHS be thanked for providing information on the implementation of the orthopaedic and stroke services following the acute services review. Secondly, that in relation to orthopaedics, United Lincolnshire Hospitals NHS Trust be commended for the high levels of performance and positive patient feedback received. And thirdly, that in relation to stroke services, a further update be received in 12 months on the impact of the closure of the stroke ward in Boston, including any plans for improvements in advance of the construction of the new unit at Lincoln County Hospital. Do I have a second for my proposal? Councillor Hayes, thank you. All those in favour, please show. Thank you, that's supported unanimously, and thank you once again to our presenters. We'll now move on to agenda item 7. General practice, quality assurance and improvement. This item was circulated as part of the agenda pack on pages 59 to 62. Our presenters are Nick Blake, Programme Director, Primary Care, and potentially Wendy Martin, if in attendance yet. Do we know if they're in attendance yet?
Excuse me, Chairman. Yes, Nick Blake is joining earlier than the time, but he's not quite there yet. I wonder if we wanted to move on and cover item 8 in the next few minutes before his arrival. Thank you.
Yes, certainly. We'll move over to agenda item 8, in which case, so we're looking at the potential scrutiny reviews for Scrutiny Panel A. Simon, I'll hand back across to you in which case.
Thank you, Chairman. So just drawing the committee's attention to page 63 and following, for members of the County Council, this will be familiar because this has been on other scrutiny committee agendas during October. It is essentially an item which all scrutiny committees are being asked to consider if they wish to put forward topics for in-depth review. I won't sort of go into any detail. As this committee is the last one in the cycle, we have the benefit of knowing what other committees have gone first, and I am aware that there have been suggestions from the Children and Young People Scrutiny Committee, one of which is on young carers. There is also a suggestion from Public Protection and Communities Scrutiny Committee on vaping, but there are at this stage 4 suggestions in all. I would like to also mention another factor in this is that we have made some initial had some initial discussions with NHS colleagues about their ability to support a sort of an in-depth review, and it doesn't look like they would be in a position to give it a sort of an overwhelming resource, but I know that shouldn't necessarily be a final factor, but I'll stop there and take any questions on this. Thank you, Chairman.
Thank you. Yeah, before I bring anyone in, what I would say is when I had the discussion in agenda setting, a 6-month type review, that NHS colleagues didn't feel they would be in any position to be dealing with, especially over a winter period in time where they're already under immense pressures. So open to any questions, though, if anyone has any. No? Okay. In which case, Councillor Smith.
Thank you. Briefly, we had our working group on mental health, and that was very illuminating. Now, whether we can shall I say, jiggle timeframes around with potential agreement from OSMB and others, and I won't speak for other members of the committee, but I'll declare an interest being the Vice Chairman. Would it be worth looking at that in a more detailed way? Because that was very, very helpful, but there was a lot we couldn't look into because we were time constrained. And there were a lot of things we had answers to, but there was a lot of things left sort of with more questions than answers. And that's still the case now. I note in our next agenda item we are looking at, say, the impact of antidepressants, etc., and that sort of work would be ideal in that sort of environment. But I also take what you've said, Chairman, around this is probably the worst time to try and get some support from our NHS colleagues for the obvious reason of it's winter and they have enough on their plate. So it was, if there's anything we can do around that in the summertime.
Yeah, thank you, Councillor Smith. I'm happy to take on board any comments such as that. What I would say is that we have done very in-depth sort of covering of the mental health side of things. I think that we've already gone through the working group. It is coming back. We've still got other items being programmed. And again, without trying to detract from it, winter pressures become summer pressures. And I think the NHS's view was very much so that they'd rather there was no scrutiny panels coming from the county council if possible. But we'll bear it in mind, and certainly, you know, it's something we can feed back. But my suggestion for now is that we don't put anything through on that particular basis. So I'm on. Councillor Mackinson-Saunders.
I just wondered if there was any mileage in looking at the role of volunteers within the NHS within Lincolnshire, because I think a lot of services would collapse without the role of the volunteers. So just a thought.
Yeah, Simon, I don't know if that's something that can be picked up on.
It could be put forward, and it is a matter for the committee to put forward that as a suggestion to the Scrutiny Management Board, or alternatively, it could be something that this committee may wish to seek, you know, items on this committee's agenda, as it is, you know, focusing on the contribution of the voluntary sector to the NHS. But I say that is a matter for the committee. Thank you. Yeah, Councillor Mackinson-Saunders, I don't know what you feel about that. We could certainly have an item here anyway. So, yeah, so if we put that forward for, obviously, our last item to ensure that that's added to the work programme instead, I think that would be probably for the best. So, in which case, I think my suggestion is that we don't, at this moment in time, pursue an item coming from this committee. Councillor Kendrick?
All I was going to say, Mr. Chairman, is obviously having managed volunteer services for LPFT for many, many years, a focus on volunteering also with the third sector involvement as well might be worth looking at sometime in the future. Thanks.
Thank you, Councillor Kendrick. So I've made my suggestion. We don't take anything forwards for the moment in time. However, we'll pick up some of the points that have been raised on our moving forwards action plan. So do I have a seconder for that? Thank you, Councillor Wootton. All those in favour, in which case, please show. Supported unanimously. Thank you. In which case, I think we can now move back to agenda item 7, because I believe that Nick is now here. Is it just Nick? Yeah. Okay, in which case, Nick, welcome to this morning's meeting. If you'd like to just walk us through in about 10 minutes and take questions at the end, if possible, please. Thank you.
Thank you, Councillor. Yes, so I'm hoping my colleague Wendy Martin will be able to join as well, and she'll be able to give a little bit more detail on any questions relating to the quality team and the quality assurance process. But just very briefly, I'll run through the paper. Obviously, we set out in the paper the process that we undertake as routinely to assure quality with GP practices. In short, the quality team have a schedule of visits. They'll go out and visit practices, look at a range of data, gather soft intelligence through complaints, CQC, friends and family questionnaires, and the National GP Survey, and use that to inform those visits, and also review the quality assurance process within those practices. Those discussions are then carried out through a monthly meeting that involves the quality team and the primary care commissioning team, and we also involve GP clinical leads as well, where we'll review practices based on a kind of a risk stratification approach. We'll pick up all the issues relating to service delivery, quality concerns, estates, etc., workforce, and review those practices and rate them using a standard risk matrix. That will then inform further kind of visits. I think Wendy in the paper set out the kind of level of visits they undertake from level 1 to 3, so fairly routine through to more intensive support. And that those intensive visits and intensive support are usually triggered by significant issues. So either things that the quality team are aware of that come through complaints or by the CQC. And then the support that's provided to the practices to address those quality issues is agreed with the practice and fairly bespoke depending on what the practice needs. So there's a regular monitoring process that involves site visits, reviewing of data, etc. And then the other element I wanted to pick up within the report, we picked up in the report, was some of the new developments as a result of the introduction of the Primary Care Access Recovery Plan. So the Primary Care Access Recovery Plan is really around supporting people accessing their GP practice. And part of that is the introduction of modern GP access, so really trying to support GP practices to take on board new telephony systems, use online consultation systems, and also look at their operational processes to really support people being able to get an appointment at their GP practice when they need it. The two kind of main commitments in the Access to Recovery Plan are trying to reduce the 8 a.m. rush, so people ringing up 8 a.m. in the morning to get an appointment, and also for people to find out what's going to happen when they contact the practice, so they're not asked to call back another day. So they find out on the day when they call, are they going to have an appointment today, or will they be booked in over the next couple of weeks? The kind of quality elements relating to this and the support level framework and the GP improvement programme are part of this, and the support level framework is a diagnostic tool which we will be rolling out with practices this year and into next year, and it goes through 6 domains, looking at a range of things such as safety, patient experience, leadership, etc. We run through that with the practice, and then I identify up to 3 areas the practice wants to focus on, and we will support them with to develop. So that could be improving telephone response times, etc., or developing leadership within the practice to develop and maintain quality improvements. And there is a national offer as well, the General Practice Improvement Programme. There's an intensive and intermediate offer, and that can range from practices attending webinars, finding out about best practice and thinking about how they would apply those into the practice, to more intensive support where a facilitator will go into the practice and agree an action plan with the practice and the ICB, and then support's provided for the practice to deliver those improvements. So again, covering those 6 domains which are covered in the report. So again, I think those are kind of important factors to bear in mind when you think about the overall quality picture, particularly in relation to access, but beyond that into the quality of care as well. So I won't say too much more. I think we've covered most of that in the report, but very happy to take any questions or comments from the committee, of course.
Thank you very much, Nick. I've got Councillor Cleaver first, please.
Thank you, Mr. Chairman. Thank you for the report, Nick. It's good to be made aware of what goes on in the background, to check up on the performances of our primary care providers within Lincolnshire, who are always very important to us all. So thank you for that. It's really good to have this knowledge. Just a few sort of questions of detail, really. In the first sentence in the background section on page 59, it mentions locality primary care quality and operational assurance groups. How are localities defined? How big are they? And how many of them are there? And who sits on these groups, please? In relation to the packages of support, again, thank you for that level of detail. Do the GP services, GP providers, actually put any financial support into the costs of particularly the level 2 and level 3 support that obviously you have to give or are offering from the centre? Next, more importantly, how many GP services are there actually at each level, 1, 2 and 3 within the county? Could you tell us that? And it would be very interesting, obviously, for us as a scrutiny committee to monitor that over time. And finally, I guess an obvious question, how is the effectiveness of the support monitored? And how are lessons learnt from the monitoring fed back through the system? Thank you.
Thank you, Councillor Cleaver. So first of all, localities. So we have 4 locality quality assurance and oversight groups. They're based on the old CCG footprint. So we have, I beg your pardon, there are 3 in total because South and South West are combined. So we have a West group, an East group, and a South Southwest combined group. In terms of who sits on those, that is members of the quality team, and they're chaired by somebody from the quality team. We have ICB primary care team members as well, and GP clinical leads are involved in those meetings too. We also have performance and informatics team members too. So one of the bits of information that goes to the group is a range of performance metrics which kind of support the overview of quality out of the practices. So that'll cover things like prescribing indicators, the quality outcomes framework, GP workforce and non-GP workforce, etc. So it gives some background to the quality discussions. In terms of the financials or the support available to practices, depending on the level of support required, the actions are principally owned by the GP practice, and we'll be looking for the practice to deliver those actions using the resources they have at their disposal initially. We would wrap around additional support as required, and the main form of support that we offer would be ICB team time. So, for example, if there was a dispensing issue, we would talk to our medicines optimization team and they could go in and provide support, but delivery action would still be the responsibility of the practice. We do commission and fund some support from the local medical committee as well. That is support the ICB pays for, and they would go in to provide that. But generally speaking, the resources, funding to make the changes, etc., should come from the GP practice. On to the next question, and I'm glad my colleague Wendy has joined. Wendy, Councillor Cleaver was asking, in terms of the levels 1, 2 and 3 for support for practice, so routine, enhanced and intensive, do we have figures on the number of practices at each of those levels currently?
Yeah, so we also have, and it says in the paper, sorry, Wendy Martin, Associate Director of Nursing and Quality with the ICB. We also have a sort of primary care quality oversight group meeting, which considers the information that comes up from those locality groups. And we probably have about 10 practices that are on our sort of medium to high risk rating, with about 3 or 4 that are on a very high risk rating, and those intensity of levels in terms of support match those risk ratings really. So we tend to have about 10 practices that are on a medium level of support, and then 3 or 4 that are on that intense level of support. So hopefully that answers that query.
Thank you. Yeah, thanks for coming in there, Wendy. And then finally, there's a question around how does the ICB review the effectiveness of the support offered and pick up any lessons learned from that. I think on a broad level, those are picked up through the county level quality assurance and oversight group. We also report through to PC3 in terms of the support offered to practices, and I think obviously one of the key ways that we review that is when we review risk ratings and issues for the practices. So what we would look to do is see those, we monitor that through seeing those risk ratings, hopefully reducing over time. So that's a kind of I guess a main way of viewing the effectiveness of that support. But lessons learned picked up through those quality assurance oversight groups that are 3 at locality level and 1 at the county level that Wendy mentioned.
And also just to add to that, then obviously if we've got a practice that's having that intense level of support, we will be visiting that practice regularly just to ensure that we formulate an action plan with that practice and sort of measure them against their actions for achievement when we do the visits, just to ensure that any support actions that we're putting in and any actions that they're taking are having the effect in terms of driving those improvements.
Thank you. Sorry, I didn't hear that very clearly. I beg your pardon. The last part there, the sound quality is not very good at the moment on this one.
Sorry, I was just saying that in addition to what Nick said in terms of that, how do we ensure the effectiveness of the support that we're putting in there? We also do those practices that are at higher levels of support need. We do regular visits to those practices. They will have an action plan of improvement, and we will be going in to ensure that the improvements are being made at an appropriate time frame through those sort of follow-up visits that take place with those practices.
Thank you. I think my point was of that final question is whether you learn things from the high level of interaction you have with the high and medium people that then feeds back to the level 1 people to make sure they don't become level 2 and 3 practices. I think that was the point of the feedback loop I was trying to make.
Yeah, thank you. So we do that in terms of we then through our clinical forums, if there's anything that's come out as a sort of general learning point for our practices, that is fed back through those clinical forums to all practices. And we also have a regular primary care newsletter, so if there is any sort of learning that comes through, that goes out through to all our practices as well.
Thank you very much for that. Thank you.
Thank you. Councillor Allen, next please.
Thank you, Chairman. The point that Councillor Cleaver made right at the end there is the one that was interesting me, because anything that improves the quality of care for patients in the primary care sector, I think, is obviously very, very welcome. You know, that's what they're there for, and that's what they should do. And they've got a significant ability to ensure health, particularly when there's a need to go into the hospital situation, because of things that they've picked up. What worries me a little bit is that what we tend to concentrate on is the poor performing practices, and we send our QCC goes in and gives them kicking around a bit, and then there's an action plan comes from that, and it does seem as though something very, very similar occurs here. But from what I see, the action plans seem to be fairly unsophisticated, if that's the word. I was going to say superficial, but it's all to do with with complaints that have been received. It's to do with waiting times with people on the telephones and all those sorts of things. Whilst those are important, it's really the outcomes of your contact within the primary care sector that's important. Is the doctor picking up, the health concerns that you're talking about? Is he picking up health concerns that you don't know about at the moment and perhaps might be important to actually deal with? And I do wonder why that isn't necessarily incorporated into these care quality sort of reviews, because that's really what it's about. It's the outcomes for the patients in terms of their involvements with the doctors, the GPs, and the GP's staff. So I do wonder, yes, we need to try and get, poorly performing GP practices up to speed in terms of how quickly they can deal with telephone calls and whether they've got a suitable sort of system in place, and and how long it takes to get an appointment and all those sorts of things. But are there better performing GP services that are good at picking up health concerns and dealing with those from a patient perspective, either at their practice itself or in terms of referrals onwards into the healthcare system? Because that's really what's important. And the GPs are so important there because they're the ones that know the patients, and they're the ones that see the patients on not a day-to-day basis, that's too much to expect, of course, but on a regular basis, and can perhaps see deterioration in health or concerning aspects of health that need dealing with or referring. And that doesn't seem to come into it at all. So we've got good performing practices in terms of the basics, such as telephone call and the amount of consultations that they carry out. But do we do anything then to look at the outcomes from those practices? Who's good at picking up cancer concerns, and who's good at dealing with diabetes, and who's good at doing all the various things, as opposed to a practice that perhaps doesn't care?
We do tend to, in terms of our quality, when we look at the quality information for our practices, it's a whole host of information. So it will be looking at that outcome information. It will be looking at sort of patient voice information that we receive in terms of experience, both from Health Watch in terms of issues that are raised through that for that practice through Health Watch. GP survey information. We also look, sort of liaise regularly with the practices that have got patient participation groups to see what's coming through those groups. So what we try to encourage through that quality surveillance is looking at all those information sources, both outcome and also performance information. So we do try and sort of triangulate all that to form our picture, which informs our risk rating for each practice. So I would say that, yeah, we're trying to do that at all times. You know, certainly there's always room for improvement in terms of how we look at that, but we do have that sort of overview look at everything for that practice, not just those access concerns, for example.
Yeah, if I could come in just to give a little bit more detail to what Wendy said, and we will look at things like disease registers. So is a GP practice identifying people with, for example, heart failure or high blood pressure, etc. We look at a range of metrics around prescribing, and I think it's fair to say some of these are proxy indicators, but probably the best data that we have. So we look at things like antibiotic prescribing, pain management prescribing, etc., against the population within the GP practice. And we'll look at other things like are people with diabetes having all the checks that they should be having, so foot checks, etc. Are people with mental health issues, are they having a range of physical health checks as well? There's a whole list of these. I won't go through in too much detail because I could be here all day. But these are all things that form. And I mentioned, I think earlier, we do have a kind of a performance pack which goes to these quality groups by practice. We can see how the practice is doing against a lot of these indicators. And although in isolation they might not be particularly helpful in viewing the quality of the outcomes for the patients of that practice, I think together with some of the soft intelligence as well, they give us a reasonable picture.
Can I come back, Chairman, with your permission? Well, I don't think the response was particularly detailed, to be honest. You get information from patients that are presenting at the surgeries with a particular issue. So it might be diabetes, but they're not presenting, you know, in terms of pains in the chest. And some GPs will just look at one aspect of that and not the other aspect. So I think, you know, that sort of monitoring is useful, but it's not really what I was talking about. It's more to do with finding the things that aren't being presented, and it's finding the things from the patients that perhaps aren't coming to the surgery, because that is really what it should be about, is finding things before they become a significant issue, become a significant demand on the National Health Service. I certainly have been called once to my GP for what was sort of called an MOT, where they did go through a series of blood tests and a series of tests, you know, fairly detailed ones and probably fairly useful. But it was only because the NHS was paying them to do so, an extra sum of money. I'm told that I'm not due for another one for 5 years from that one. Well, a lot can happen in 5 years, and I suppose it does depend whether the GP practice is being paid again to actually go about doing it, and some GP practices will be proactive in taking advantage of what's on offer. Some GP practices won't be. So I don't know whether everybody in Lincolnshire at 70 is getting a MOT or not.
Eric, you'd like to come in?
Yeah, I think what Councillor Allen's flagging up is a really important issue, but it's quite complex. So the example of a health check, for example, is actually something that statutorily the County Council has responsibility for commissioning, and as you say, we pay GP practices to do it, and we do pay close attention to the uptake and delivery of the quality of the health check. But it's every 5 years, and it's only if you're not known to the practice already. So there's a whole range of issues there. I think the argument around how do we as a system, and we can maybe talk about practice or GP practices, but they're only part of a system, proactively manage their health and well-being, including people who've got existing illnesses at a community level, is probably the big challenge for the next 5 years. Because if we don't get that right, we simply cannot keep throwing money into acute sector, as we've heard throughout Scrutiny today. So I think it's a really important question. It might be one that Scrutiny would want to come back to and unpick a little bit more. NHS England talk about population health management, which is understanding what the population health requirements are at a local level. And we've not really picked up, it mentioned in passing in the document around primary care networks and the responsibility of primary care networks to manage those populations at a bigger level. I think GP practice lists are really, really important in this. But just like we were hearing with the acute sector, some things make sense to do at every GP practice level. Some things make sense to do at a bigger geography, and it might not be delivered by a GP practice. It might be the community trust, or it might be a different model that needs to be delivered. So it's a really important, really key question for the health and care system going forwards. But I think it probably needs a lot more time and structure to unpick it.
Okay, thank you, Derek. Thank you for that answer. Got Councillor Geeney next, please.
Sorry. Thank you, Chairman. And I'm sure not the only person, often gets people locally grumbling about something that's happened at their GP practice, but they haven't said anything to the practice because they're afraid that if their name comes up as somebody that's complaining, they may be penalised in some way, anything from not getting probably the attention they would like to being asked to move to another GP practice. They actually are afraid to say anything, so they're grumbling amongst people. I mean, one case was heard was a GP practice actually prescribing the wrong medication because it was spelt similarly to the one they should have prescribed. Fortunately, there was a medical person in the family that saw the prescription and said, if you take that, it could be fatal, and they got them to get it sorted out. My question is, first of all, is there any way that there is a path that patients can complain without it actually going through the GP's practice themselves? Is there something advertised where people, if they do have a serious problem with a GP, can complain, and a way of protecting people that are afraid to complain so that they don't find themselves penalised and in a very difficult position? Thank you.
So, do you want me to pick that one up, Ned? I was just going to say, we do always try and encourage patients to go through the GP in the first instance with the complaint, but accepting what's been said in terms of that worry about implications and the fear of doing that, there is also a route to raise the complaint through NHS East Midlands primary care team now, which covers off complaints for primary care. So there are two routes. I mean, the first one we would always encourage is through the practice, but as you say, just to counter that, there is another route as well, which we can share if that would be useful.
Yeah, and another couple of routes that patients may want to consider if they want to make a complaint, they can come through to the ICB's feedback team, and we will regularly pick up complaints from patients through that route. We always ask patients whether they want us to let the practice know that they've contacted us by name, or whether we should raise it as a general issue. And depending on the nature of the complaint, obviously would depend on how we would approach that. But that's another route. And people can and do complain through to the CQC as well, and the CQC will pick up patient complaints. So there's a range of routes people can take if they want to complain. But as Wendy said, I think it's ideal if the patients complain directly to the practice, and the practice can get into the detail of what the complaint is. I should say that we'd always want to support patients if there are any issues or they felt they were being treated inequitably by the practice due to the fact that they'd raised a complaint. That would be something that we would take quite seriously.
Liz?
Sorry, can
I? Yeah, it was just really to support Wendy and Nick on that explanation. Obviously, as Health Watch, we sit there as an independent organisation and do take concerns from patients and then supply those to whichever organisation to respond to us in 20 working days, and all the organisations are very proactive in doing that. So there is that opportunity, as well as obviously trying to deal with a complaint directly with the organisations, but that would be another offer of support.
Yes, what was said in there, could it please be shared so that if we do get people sort of saying, well, I don't speak to the GP, but we could actually direct them where they could make the complaint without their name being disclosed to the GP practice?
Yeah, no problem at all.
I will say Health Watch links are always excellent as well. So it's very recommended. I think I've had a few through there and they've been superb. So credit where it's due. Thank you. I've got Councillor Smith next, please.
Thank you, Chairman. On a similar vein, I've had this issue a number of times myself, and it will be, oh, it's the same medication, we've changed the branding. Now, the amount of times I've had that said to me and the amount of times it's actually impacted me, I've lost count, Chairman. And the suspicion is, and I can't prove it, but I am sure it's basically done because it's actually a cheaper version of what they were previously prescribing. Now, how is that assessed? How often that's done to patients? Because one example, they changed my I'm an epileptic, and they changed my medication. Now, I was in bed for 3 days with this because, oh, it's the same medication, Mr. Smith, we've just changed your branding. Well, it didn't sit. All I'll say is I was very ill. And if it got much worse, I think my mother would have taken me to hospital because it was that serious. Thankfully, I wasn't driving at that time, because that could have had major implications on my licence and my life as a result. That's just one example. I've got, there is another example, and now I'm, as a result, basically paying for a prescription that I should get through the NHS, which I now can't because I can't be guaranteed I will regularly get the brand of medication I require, so I'm now paying for it, which defeats the point of national insurance, Chairman, but I won't go into that rant now. So what can we do to ensure that as regulators and people who assess this, that we actually monitor that? Because that seems to be happening ever increasingly frequently, Chairman. And during one of the other times, I thought, oh, it's a supply issue, or it's becoming far too frequent, Chairman, to be a supply issue. It seems to me to be a financial issue. And if that's the case, then GPs and others need to be very honest and say, no, this is a financial issue. And then patients need to be able to have proper redress where they can have redress done correctly, because at present there isn't any, Chairman, and that needs to change because it's becoming far too frequent now.
Sorry, Nick, you go first, and if you're not covered what I was going to say, I'll pick it up.
Okay, thanks, Wendy. Yeah, so it's very difficult to talk generally about this. There could be a range of reasons why medication is changed. That could be as a result of supply issues, and those I think it's fair to say they're increasing. There's an increasing level of supply issues for some medications, not all, but certainly we get copied into supply issue notifications, and they seem to be coming through more regularly, or have done recently. So I think that's one of the issues. It could be around prescribing policy with the ICB. So we will look to ensure that we're making best use of the funding we have available to us and supporting GP practices to prescribe accordingly. That's usually managed through our medicines optimisation team, but that really would be a case of changing medications where there shouldn't be any, there wouldn't be any clinical impact on the patient. So those are the two main issues I wanted to comment on. I think if the committee would like to get into the detail a little bit more around prescribing, it might be helpful to include some colleagues from our medicines optimisation team, who they would be the kind of team that support practices around prescribing and kind of work with practice on some of these issues. So they would be able to provide a bit more detail. So that's just something for the committee to consider. But I don't know, was there anything else you wanted to add in there?
No, I suppose it was just, and I'm sure the colleague has done this, but if if the medication is really not suitable and controlling symptoms, then obviously there's that dialogue with GP to get a medication prescribed that will do that. So it's strange that the medication that is needing to be paid for. So maybe that's one that could be shared with us individually, so we can just follow that up and ensure that that is a need in terms of having to fund that individually.
Thank you, Chairman. The short answer to that sounds very much like it's financial to me. And that in my instance, and I'll use my own instance, I had the exact same spiel of, oh, it won't affect you in any way at all, Mr. Smith. Well, I can guarantee you it did. I was bedridden for 3 days. And thankfully I didn't have a seizure, but by God did I not feel well. So I think there needs to be a cognizance that actually some people are exceedingly sensitive to any form of medical change, even if it's branding. And that actually, if it works, and it has worked for years and years and years, it should be left alone, because unless there is a supply issue, which then I accept, otherwise it should be left alone unless that patient's medical needs change, because you're playing with essentially somebody's life on the basis of money, is what it seems to me, Chairman. And I think we need to go into this in a bit more detail with your permission, because I've had this on, and not just with myself, but with other people on a number of instances. And it's becoming an increasing issue, Chairman, and it's, quite frankly, it's not on, Chairman. If it's monetary, just be honest and say it's a monetary issue, and then we can have that proper dialogue as representatives of our residents, and they can also have that dialogue that they feel they need to, with whether it be the presenters themselves, or NHSE, or NICE, or whoever it needs to be, the CQC, or whoever.
Thank you, Councillor Smith. I'm sure we can pick that up in the work programme and see what can be taken forwards from it. Okay, I have no speakers left in. Oh, Councillor Mackinson-Saunders, and then Councillor Welbury after.
How would we as patients know that our GP surgeries were having problems, that they were lacking quality? I think the GP surgery I go to, which I've been going to since before I was born, I would say was not as good as certainly nowhere near as good as it used to be. And I just want to praise the urgent care department at Louth Hospital, because without them, we'd be totally lost. They are brilliant. But I am concerned how patients would know about what's going on in their individual practices.
So the only rating for practices that is published is in terms of the CQC rating, which is on their website. And obviously the patient survey, GP survey information is also publicly available in terms of what patients are saying about their practice. So they're two publicly available pieces of information that you can access just to understand how the CQC's rated your practice, and also how patients are rating the practice. I'm not sure that there's anything else that we publicly make available that rates each practice from a quality perspective. We obviously have an awareness of that for each practice, and take action appropriately to drive improvements where we do identify concerns.
I think the patients might disagree with some of the report.
Okay, thank you. Councillor Welbury.
My question is regarding large organisations that run NHS practices. I'm thinking particularly of Evergreen, who are not your cosy local GP. They're a massive organisation. Just wondered what contractual obligations they had towards any scrutiny, and what the relationship is, if it's different to a one-off practice, or is there a different kind of contract with large organisations to run GP surgeries?
The short answer is no. The contract is effectively the same, whether it be a single-handed small GP practice or a practice that's part of a larger organisation. The contracts and the terms and conditions are the same. There's a couple of different types of GP contract, but again, they're broadly the same in terms of what's required. And again, it makes no difference whether it's a large organisation or a small partnership.
And just in terms of quality, we look at that organisation in terms of its quality for each individual practice.
What sort of
Say
input,
that again.
Sorry.
Yeah.
What sort of input do they have into your work?
We'll
as
know
a
more.
large
See you later.
organisation? Sorry.
That's right. Councillor Matthews, I think you're not on silent, and you're coming across in the chamber. You could just pop yourself on silent while the questions.
Thank you very much. Bye. Sorry, Carl.
That's okay.
No, as a large organisation, you know, they have probably more weight than a small practice. And I wondered what involvement you actually have with them, and what notice they actually take of your recommendations.
So we do meet with the leads for those organisations in terms of those discussions. If we've got any quality issues with the practice, we'll meet with their leadership team and ensure that they're sort of fully supportive in terms of the improvement actions that are required for their practices that they may have in Lincolnshire. So that's the involvement. We would expect them to sort of deliver on any improvements as we would any other individual practice that's not part of a large organisation. We'd equally expect them to be driving the improvements and driving that at their leadership level as well.
Do you have KPIs with Evergreen and those kind of organisations? Separate KPIs, because they are such large companies and they do have contracts with the NHS across many different fields.
Nick's probably a better place to answer, but we do, you know, if we've got a contract with them for delivery of a service, we will have KPIs for that delivery of the service. So each of our contracts, NHS contracts, we have that a quality assurance mechanism and KPIs that go with that contract.
I mean, I guess very much in brief, we would treat a GP practice as a GP practice, whether it was part of a large organisation or whether it was a standalone practice, and they'd have the same KPIs, performance metrics, quality measures, etc. So we treat them all the same. I think, as Wendy was saying, we might have slightly different dialogue with a larger organisation just because of how they structure themselves and how they manage the service. But in terms of the KPIs and metrics, they would be exactly the same.
Okay, thank you.
Thank you, Councillor Welbury, and sorry for your interruption there for a minute. I don't have anyone else that has raised to speak, so I've just got 3 questions myself, if I may. My first question is, can I confirm that currently there is 1 GP practice out of 81 rated as, put my teeth in, as inadequate in Lincolnshire, and how does that proportion compare to other ICB areas, please?
So currently we have 3 practices that are rated as inadequate. One's just been awarded an inadequate status with publication of the CQC report at the beginning of October. That's Richmond practice. The other practice that's inadequate is Cascade. Branston practice is also currently rated as inadequate, but that's at a recent CQC re-inspection, although the report's not yet published. We are of the understanding that they will move out of that rated and to an improved rating. So we will have 2 inadequate rated practices. Sorry, I missed the end of the question. Was there another part to the question? Oh, sorry, I missed that.
That was all of the question apart from the proportion compared to other ICB areas, sorry.
So in proportion, in contrast to other ICB areas, actually we've got a low rate of inadequate practices and a low rate of requires improvement practices. But I suppose just to bear in mind that quite a few practices have not been inspected since before COVID from a CQC perspective. So there are quite a few inspections currently ongoing in our ICB and across other ICBs. But again, CQC do that on a risk rating an analysis of which ones are presenting as more risky in terms of what informs their inspection regime.
Okay, thank you. Has the ICB needed to support applications for Section 19 funding for any practices in Lincolnshire?
Section 96, yes, we have reviewed that. It's pretty rare that happens, and usually there are other ways of supporting the practice. But on occasion we do receive requests for Section 96 funding. We've had one recently this year. I think we've had one over the last 12 months that I'm aware of that we've looked at.
Okay, thank you. And then just building on from really what was said in one, I suppose, is how much credit is due to the ICB's support for Branston and Hate and Family Practice receiving a rating of good in October when it had been rated inadequate prior to this?
I think not to take any credit away from the practice, because obviously there's a lot of work that the practice undertakes in terms of making those improvements. I'd like to think that in terms of our support, that has helped drive that improvement in terms of working with them to understand what their needs were in terms of improvements, and then supporting where possible from our teams to give that additional support in areas that were wanted.
Okay, thank you very much. In which case, as there's no further questions, I'm going to propose that the activities of the NHS Lincolnshire Integrated Care Board supporting GP practices and need of improvement be noted. Do I have a seconder for my proposal? Councillor Allen. All those in favour, please show. Thank you. Supported. Okay, and once again, thank you for your attendance this afternoon. We'll now move on to agenda item 9, the work programme. Simon.
Thank you, Chairman. If I could ask members of the committee to refer to page 71 of the agenda pack. Just looking at the next meeting, the item on GP provision is also going to include the something called the Primary Care Access Recovery Plan, which is something the ICB has been developing. It will also pick up from the committee's working group earlier this year, calendar year, on the support in GP practices for mental health, and it's also going to pick up another topic as part of sort of the overall stats that are circulated on the number of did not attend appointments. So that's going to be quite a substantial item, and also include the Lincolnshire Local Medical Committee. So that's going to be a substantial item next time. The next item is also picking up, and it's the final round of LPFT items picking up from the working group, and this is what is covering specialist services, which is learning disability and a number of other services such as veteran services. There's quite a long list of what services covered by that. So that is that item. And I won't go through each of the items. I will be looking at the January meeting just to, as it looks a little bit thin at the moment, well, is thin at the moment, and I'll be perhaps bringing forward some of the suggestions from the meeting, which include third sector, the contribution of volunteer services to NHS. And there was also an email from Councillor Cleaver just before the meeting, which I understand was in relation to specifically if I've read it correctly, out of hours services in Stamford, out of hours GP services in the Stamford area. And there is also a question about an item on integration. I think I've read things correctly. Anyway, thank you, Chairman.
Thank you. Councillor Rogers.
Thank you, Chairman. As the District Councillor for Welton and Dunholm, you're all aware of the potential arrival of 2,000 asylum seekers, which they've had the judicial review, and obviously I'm liaising with Councillor Bunny, who is our chairman and is in the picture with this. Because of the imminent arrival, I've been in touch with Welton Family Health Centre to see what impact it was going to have on them. Now, the response was, I asked for the impact for the use of RAF Scampton for adult male asylum seekers. They came back and said, as far as they are aware, GP services for asylum seekers has been awarded to an out-of-county company that will oversee all aspects of primary care, so there will be no impact on their patients. However, they have not been in any consultation and are not made aware of any provision for secondary care, 111 and A&E services. So it could have a potential impact on patients for the health centre and longer waits. So I really do think I would like to ask that this is a potential topic for scrutiny, please. Thank you.
I'll bring Derek in at the moment. It is actually on the list of items to be programmed at number 2. So we've got it down, but it does need to be moving up, I would suggest, onto the agenda as soon as possible, realistically. Derek.
Thank you, Chair. Sarah J. Mills, who'll be here at the next scrutiny, is leading on the provision on Scampton, so it may be timely if you include it at the same time. I'm sure at that point Sarah J. will be able to update scrutiny.
Yes, Councillor Rogers.
Well, you know, as we know, the judicial review has been heard. We do not know what the outcome is going to be. I think if Councillor Bunny will, they think maybe a month's time, but we don't know. So there is huge worry within the community of Welton and Dunholm, obviously. This has been a topic of conversation and part of my agenda since March. So I am trying to take questions on a daily basis. So, you know, it's something that I think must be discussed sooner rather than later.
Certainly, and Simon, I think, has picked up on that, and we'll try and ensure we have an item as soon as possible. Thank you. Councillor Wood.
My question's already been answered by Councillor Rogers. Thank you.
Okay, thank you. In which case, Councillor Cleaver, please.
Thank you. Yes, just to give the committee some more detail as to what I was specifically asking for possible items to be added to the work programme. The more important and key one, I think, is local strategic planning of integrated health provision, because I thought this was supposed to be beginning to take place 18 months to 2 years ago when the ICB was created. And at the moment, I've seen no sign of it happening. You know, no one appears to be putting together a strategic plan for Lincoln, or a strategic plan for Boston, or a strategic plan for Grantham. And I'm wondering where we are with that. So I think it's something that we should be scrutinising and saying, where is this, what's happening with it? That's the more important one. The one that was referred to by Simon, slightly more minor, and it comes from a piece of casework that I had. We discovered that in Stamford, obviously surrounded by borders, Rutland and Cambridge, Peterborough, Cambridge on 2 sides. There is a GP practice whose catchment area covers Stamford. So quite rightly, people register with them. But they are actually based in Empingham, which is a village in Rutland. So they are funded through the LLR ICB. Fine. Works perfectly. Not a problem. However, when those people dial 111 for an out-of-hours service, they are told, no, you can't go to Stamford Hospital GP out-of-hours service, which is funded by Links ICB. You've got to go to somewhere that's funded by LNR in Rutland or Leicestershire. And obviously people are rightly aggrieved, saying, well, actually, I've registered with a GP service whose catchment area includes my address in Stamford. Why can't I go to Stamford? So there's an issue there. I don't know how we phrase it for putting into the work programme, but clearly there's both a contractual issue about the way that out-of-hours GP services are contracted, then also the question of how 111 actually do direct people. So I just want to raise that. I don't know how we can, as a scrutiny committee, raise it, because it's a matter of concern, I think, for anyone that lives around a border area.
If you leave that one with us, we'll pick it up now. But what I'm thinking is, when we're doing agenda setting, we can have that discussion with our NHS colleagues to try and bottom it out, I suppose. It does seem quite strange what they're saying, especially when we are still supposed to have patient choice, of course. You did, yeah. Well, I've not had the chance yet. So, but yeah, we'll pick it up and come back to you and make sure that it appears somewhere, and liaise obviously on what our NHS colleagues have got to say realistically on it.
Thank you, Chairman.
Thank you. Anything else on the work programme? No, I think there's a considerable amount listed there as well to be programmed on, so we'll start trying to work our way through the list as well and prioritise those. So, okay, are we all happy with the work programme moving forward? Thank you, that's it, great. Okay, well that brings the meeting to a close, and thank you all very much for your attendance. Thank you.